So hello everyone, I'm Julie from year 2 and inshallah today we'll be doing a physiology crash course with my colleague Naya. Naya will join us in a bit. I'll be covering reproductive puberty and conception. Naya will be doing CVS and blood pressure, tamam? So we'll start with the reproductive system, physiology of reproductive, and feel free to stop me at any time. And I'll just go over things which I think are easy. I might do it quickly because I don't want you to stay here for long. Especially, I think CVS is heavy, so I want to finish this quickly, but you feel free to stop me at any time. Hala, reproductive system, we know it's unique because this is the first slide of the lecture. It's just an introduction. It's telling you it doesn't contribute to homeostasis. It's not essential for survival. If a person doesn't have the reproductive organs, they can still survive, but they will be infertile. And it is responsible for continuation of the species because we reproduce using the reproductive system, and that's why it's unique. Hala, there's this question. Why does a disruption at any level of the hypothalamic pituitary gonadal axis lead to infertility, even when the reproductive organs themselves are fine?
You need hormones for the reproductive organs to work?
Yes.
We need the hormones to provide the gametes, which are necessary.
Exactly. So it's all interconnected. It's not solely dependent on the reproductive organ, that they are all interconnected. The whole axis is important for the thing. Hala, you guys mentioned gonads. The primary gonads we have are testes in males and ovaries in females. And they have two functions. As you guys mentioned, gametogenesis, which is producing the actual sex cells, and the sex hormones. For gametogenesis, for males, sperms, females, eggs, and then for the sex hormones, testosterone for males and estrogen and progesterone in females. Just an info for you guys to know, we have both hormones in all of us. So it doesn't mean that males only have testosterone and females only have estrogen. Females also have testosterone and males also have estrogen hormone, but it's about the concentration and who is dominant. Okay, let's start with the male reproductive system. As we said, formation of sperms, hormonal regulation of the male reproductive functions, and of course the performance of the male sexual act. So we're going to look at the anatomy. Is it clear or something blocking me? Okay. Hala, to look at it, the circles, these are from the slides themselves. These were circled by the doctor, and it makes sense because this is what you are concerned with in this lecture. You're not concerned with the bladder and the urethra and all. You are concerned with, first of all, the testis, the epididymis, and the scrotum. The scrotum, you know that it's basically, because the testis cannot be inside, the body because of the temperature, because they are performing spermatogenesis, which is very sensitive to heat. So the body temperature itself is not suitable for it. That's why we need to keep it outside the body, and the scrotum is doing that basically. Okay, and we have the urethra, depending on, like for example, this is the prostate gland, right? This whole thing that's coming from the bladder onto the external urethra, this is all the urethra. Depending on what it is passing through, we name it. So for example, when it's passing through the prostate gland, it's called the prostate urethra, and when it's passing through the corpus spongiosum, we call it spongy urethra, and so on. So it really makes sense, and once you see it, it will make sense. And our main spermatogenic organ, let's say, is the testis. Everything else, such as the seminal vesicle, the prostate, and the bulbourethral gland, they are accessory. So they are producing things that are required for the semen. Okay, this is, if we look at before that, this is the testis, but we are zooming into the testis. We are seeing what is inside it. We know that this is the testis, we said this is the epididymis, and I hope I'm pronouncing it correctly. Okay, I saw someone raise their hand. So this is the epididymis. What is these things inside? Seminiferous tubules. Why are they significant?
They produce the sperm.
They are exactly where we produce the sperms, okay? So now in the next picture, I'm zooming in into one lumen, one seminiferous tubule. So I will have this spermatogonium. This is where the sperms are produced, and I have something called Sertoli cells. And the Sertoli cells, they are just for nourishment. So the actual spermatogenesis is happening here. This is helping it or nourishing it. And then in the interstitial, you have the Leydig cells, which are responsible for producing
hormone, testosterone.
Testosterone, exactly. Hala, there's something that was also mentioned in the lecture, just for you guys to see it, visualize it. Over here, these are the beginning. Now we have spermatogenesis. It starts with a spermatogonium, right? Yes. So it starts over here, and then as it's moving towards the lumen, it's becoming more developed. Meiosis is happening. Once it reaches here, this is the spermatids. So it's like moving from the base to the lumen. While it's moving, this process is happening. So closer to the base cell, mitosis is happening. The more you are going towards the lumen, you will see more meiosis and spermiogenesis. And once spermiogenesis is over, this Sertoli cells will release this the spermatids or the sperm cells, and they will be in the lumen and they will be taken up. They are taken up where? They will be taken up to the epididymis. So can we imagine it? Okay, when it goes to the epididymis, خلاص it can go. Is it ready? What do we have?
Motility.
Needs to mature.
Mature. We have two maturation that will take place in the sperm after it is produced. So spermatogenesis, spermiogenesis. And then I have two maturation. One of them is in the epididymis, and the other one, and the other one will happen where? Yes, female reproductive tract, exactly. Okay. This is just a summary of like all the organs and their functions. And we said testes, they will make the sperm and also make sex hormones, depending if we're looking at the tubule or if we're looking at the Leydig cells. Epididymis, we said maturation of sperms, or it could be just conveying it to the ductus, what was it called? Yes, exactly. Or it could just store them for now until it's ready to leave. So this is the three functions of the epididymis. And then the ductus difference is basically, it takes the sperms and then it sends them to the next part. It's just any passing. You get me? So that's what they're doing. Seminal vesicle, prostate, and bulbourethral gland, they are producing something for the semen itself. Either fructose to nourish the sperm, prostaglandin because it will help in the sperm motility. And we have the prostate produces alkaline fluid. Sperms, they love alkaline. This is why one of the difficulties they face in the female reproductive tract is acidity. This is why a lot of sperms are entering the female reproductive tract, but only one will reach the egg. A lot of them die due to the acidity. And yes, this is just like a compilation. To memorize, I don't know, do you guys know this mnemonic? 7 up? Okay. Basically, this is just to know the pathway of the sperms. It starts in the seminal tubule, S for seminal tubule, goes to the epididymis, vas deferens, which is the same as ductus deferens, goes to the ejaculatory duct, and then N is nothing, goes to urethra and then to the penis. So that's 7 up. It's to help you memorize the tract. We're going to go to spermatogenesis. First of all, how many days does this take?
64.
64 or?
74.
Yes. I see both. In one lecture I saw 64, one lecture I saw 74. But yes. And it starts with primordial germ cell. Here it is diploid, right? Mitosis takes place, it is still diploid, it is now spermatogonial. When the meiosis takes place, it becomes haploid, and then the last part, spermiogenesis, it's not meiosis or mitosis, it's just morphological changes. Because here it's a circle, but we don't want it to be a circle, we want a head and a tail and a flagella and the acrosome cap. This is all that's happening in spermiogenesis, okay? But this is just a table because I found it confusing. I just wanted to make it clear, spermatogonia and primary spermatozoid are still diploid. Once it becomes secondary and spermatids, that's the haploid part of the process. So 74 days begins at 13 years of age. Why? Because that's when? Puberty, on average, yes. When they are produced, they cannot swim or fertilize because they need maturation. Maturation must take place in two places. We said they are epididymis, partially, and then they are fully and ready for fertilization in the female reproductive tract. Any questions? Perfect. Okay, this is where I wanted to show you the basal and then the lumen. So as you can see, the spermatogonium, and then becomes a sperm until it reaches the tubule. That's when it's actually a sperm, like the way you imagine it. So this is, you just need to look how it's towards the lumen. This is the process happening. And yeah, okay. We need to look at the hormones. We need to agree on something. Everything that happens in the body, everything physical, has a hormonal event happening behind it. Because the body will not act on its own, or else things will be uncontrolled. So hormones are controlling everything. But we saw the anatomy of male reproductive tract, and we saw how spermatogenesis is taking place. But then what is controlling everything? It's the hormones, okay? We have the GnRH, okay? It will go to the anterior pituitary gland. It will release two hormones, FSH and LH. What are their full forms? And follicle stimulating. It's easy to memorize it. And follicle stimulating, it means it will act on the either spermatogenesis or in the females on the follicle itself, the egg. So it's easy. So then the LH will be more related to the hormone, since it's not related really to the actual gametogenesis part. It's related to the hormone. Let me check my notes. Okay. So basically, once the LH goes to the Leydig cells, it will tell them produce testosterone, and then testosterone will actions. It has secondary sexual characteristics. It will do that, and it will also help the spermatogenesis itself. So you need testosterone for both of them. But this is why in puberty, the males can produce sperm. Why they cannot do that before? Because this whole part is not actually acting. It is inhibited, okay? Okay, so we are talking about the hormones. We said what is testosterone. Luteinizing hormone is basically activating testosterone, and it's like helping it being released and being produced. Follicle stimulating hormone is acting directly on the spermatogenesis. It is helping the spermatogenesis to take place. It's not helping the spermatogenesis, it's helping the spermiogenesis. It is telling the Sertoli cells to convert the spermatids to sperm cells. That's a correction. And then we have the growth hormone. Growth hormone, what it is doing is basically it is involved in the early division of spermatogenesis. Yes, early division of spermatogenesis, therefore it's essential for spermatogenesis. So, for example, how is this relevant to me? Why do I, in what clinical cases can I see growth hormone being affecting infertility?
Dwarfism.
Dwarfism, pituitary dwarfism specifically. It means I have a lack of growth hormone, so the patient will be short and they will have fertility problems because spermatogonia, they are not dividing, so there's a problem in spermatogenesis. And the estrogen part is basically, remember in the beginning of the session we said that both genders have both hormones, but this is where you see it because estrogen is actually formed by testosterone by the Sertoli cells when they are stimulated by FSH. And it is probably essential for spermiogenesis. So let's go with the probably. This is how it's written in the lecture, so let's go with it. Any questions? It looks overwhelming, and this is why I prefer to study it this way. And I number the hormones, what is this function, what is this function, and I'll be able to basically memorize things. It's just easier that way. This is honestly nothing really to explain here. It's sperm and semen. They just want you to know the velocity. It's alive in the female only for 1 to 2 days. Why? Because the environment changed. It's no longer where it wanted to be in its alkaline solution, where it was happy. It's in acidity, and there is immune reactions happening in the female tract. There's a lot of things. I think we took it in the pregnancy session. Why does the sperm actually cannot survive more than 1 to 2 days? And aslan, we don't need it for more than 1 to 2 days. Why? Why is the sperm in the female tract in the first place?
Fertilization.
Yes. And
the cycle.
yes.
Menstruation.
Yes, we're also going to look into that. So basically, the ovum does not survive more than after ovulation. It will be shedded. Anyways, the window for fertilization to happen doesn't need to be more than 2 days. It makes sense. Hello, Yusuf. But recording delayed. Anyways. So this is basically the sperm after spermiogenesis took place, and acrosome and the nucleus. What does the acrosome contain? It has these two enzymes, hyaluronidase and proteolytic enzymes. Why?
Break down the zona pellucida.
Above the zona pellucida, there's
corona radiata.
Corona radiata. So yes, exactly. But this is why we don't need them in the male reproductive tract, because otherwise it will harm the organs. And that is why we need the cholesterol cap and everything to be hiding these enzymes, and we only need them to be released when I want to act on the corona radiata, which is in the female reproductive tract. But this is also another reason. Semen. If you have any questions about semen, let me know. But it's very nothing really to explain in this slide. Okay. Now we're going to the female reproductive tract. Mainly, we want to know the uterus, the ovary, fallopian tube, and the cervix and vagina. There is something I got to know in year 1, I did not know this before, that the ovary and the fallopian tube are not actually connected to each other. There is space. So once the ovum is released, the fallopian tube takes it. And there's 98% success rate. And I was surprised. I was like, how does the ovum get released? It doesn't go anywhere at once. The fallopian tube will always catch it because of the action of the cilia, stimulated by which hormone?
Progesterone.
Estrogen, yes. So the estrogen will actually act on the cilia, it will take the ovum. Okay, we took spermatogenesis, which was very easy. Mitosis, meiosis, spermiogenesis. It was very simple. It's a bit complicated. I don't like this. So we start again, next the starting point of the sperm, we started with primordial germ cell, and then mitosis is taking place, repeated cell divisions until I have the oogonium, okay? Oogonium will do meiosis 1. And this is happening before birth, right? Yes. This is all happening, before birth, the mitosis is happening at birth. It is arrested in prophase 1. Yes, so it starts meiosis before birth. Meiosis starts before birth and it stops at prophase 1. When does it continue? At puberty. And how do I remember? P and P. So at puberty, I'm at prophase 1 and then it will continue. Once it continues, it will do meiosis 2 and it will be ovulated. So it will leave the ovary. Okay? But بعدين it will not continue meiosis 2, it will stop at metaphase. When will it continue?
Sperm joins.
Yes, so if it doesn't join, خلاص, it will be shut. So there are a lot of chances where the egg doesn't necessarily have to complete meiosis 2. Okay? This is what oogenesis. If you look at the follicle development, it's very simple. I have cells growing around the oogonium. Okay? This is called the granulosa cells. And then around them I will have theca cells. That's it. The granulosa cells will start. Yes, granulosa cells, or am I mistaken? Granulosa cells will secrete an hormone. What is it?
Progesterone.
Estrogen. تمعلق على البروستات. هي estrogen. Estrogen, and it will accumulate in this. So you see here, this is the oogonium. I have granulosa cells around it, one layer only, and then the rest of the cells, the rest of the granulosa, and the rest of the theca will be around it. They are separated by this fluid in between. This contains estrogen. And what do I call this? Antrum. Okay? So over here, where is the starting point? Here, primary oocyte within follicle. It is arrested at
Prophase 1.
prophase 1. Metaphase after ovulation. So inside the ovary, it's arrested at prophase 1. The cells, the layers of cells are becoming more and more. So I had one layer of granulosa cells, I have more and more until it becomes theca, granulosa and theca, and it's growing. And then I see the buildup of fluid that contains the estrogen. This fluid is called an antrum. And this is the primary oocytes with the granulosa cells. Once it is ovulated, they will only release the secondary oocyte, which is arrested at metaphase. Yes, so primary oocyte at prophase, primary, it's very primary P, prophase P, it's until puberty, so PPP, just remember it that way. It is released. This part becomes the corpus luteum, and it will degenerate unless pregnancy happens, and we will look into that in a bit. But this is the whole cycle, they are happening together, yani the oogenesis is happening at the same time as the follicle development, let's say. The follicle development, they are looking at the cells around the oogonium. Is it confusing or does it make sense?
I have a question.
Yes.
So like when this happens, like when we reach the primary oocyte, you have the primary follicle at the same time.
Yes.
Each phase is like synced together. Okay.
Yes.
Okay.
Oogonium comes here, granulosa cell starts producing. Yes.
So yeah, before it goes there, are the oogonium and the primordial germ cell the same thing? Just like one is before it travels to.
So you're saying, are these two the same thing?
Yeah, are they the same thing?
I don't think so, because here they said there is repeated cell division, there's mitosis happening, and then it migrates to the ovarian cortex. This is where it becomes oogonium and it enters the granulosa cells. So I think they are differentiated. And if I go back to spermatogenesis, same thing. Primordial is something, becomes spermatogenesis. So I'm assuming they are separating them, yeah, they're not the same.
Do we know where they are before migrating?
Good question. I don't know, but I can look it up for you, okay? And I'll let you know. Do you know, Yusuf?
No.
This, when it goes to the ovarian cortex, it becomes oogonium. So before it goes, where was it? Not in the cortex, in the middle, right? Maybe.
Year 2 information.
Year 2 information? So they
You
don't
need to know.
Khalas, perfect. Year 3 Jana, by the way. She's coming from the future. Okay. So we have two cycles taking place simultaneously. And something happening in the ovary, this is why it's called the ovarian cycle. And then we have something happening in the uterus outside, endometrial cycle. Each one has three phases. The phases of ovarian are follicular, ovulation, luteal. The shortest is ovulation, because what's the cycle? What's the length of the cycle?
1 day. Ovulation.
لا, the ovarian cycle. Yeah, well, how long is it? 28 days. Half of it is follicular, half of it is luteal. Ovulation is 1 day.
Yes.
صح? Okay. Okay. So, endometrial cycle, this is happening with this. Again, follicular is happening, proliferative phase is happening with it. And then the luteal is corresponding with secretory phase. So they are all happening together, تمام? This is to see everything مع بعض. This is what we were discussing in the beginning. لما we looked at oogenesis and the follicular development. So we have the primary oocyte, granulosa cells, the antrum forming, ovulation, corpus luteum, degeneration. Is there something? fishy.
One day.
One hour, okay. طيب. And then the pituitary and ovarian hormone levels. This is showing you the changes in the hormone levels, how it is coinciding with the endometrial cycle, and the ovarian cycle. Guys, the ovarian cycle is the same one we discussed here. This is the ovarian cycle and what we were showing over here. Which one is the follicular and which one is the luteal in the ovarian cycle? This is what? Follicular. And this is what? Because corpus luteum and the, yeah, so it makes sense. فاحنا هلا we know what is follicular, what is luteal. This is ovulation. Simple. هلا بس we have to understand what's happening in the endometrium and in the hormones that are coinciding with these events. So, first of all, during ovulation, basically for me to actually excrete the egg, I need what? Something has to. LH surge. LH surge happens because of, yes, positive feedback of estrogen. But is this usual? And usually estrogen has a positive feedback of LH. Yeah, exactly. So this is the only time in the whole month where you will see estrogen and LH have a positive relationship. So estrogen is increasing, causing LH to increase. Other than that, it's always negative, okay? So in the beginning, I have the follicle development. So this is why I have a bit of high FSH, because it is stimulating the follicle to develop. But the estrogen now, it will increase. This will cause the LH to increase, ovulation takes place, and then corpus luteum will be produced. Corpus luteum is producing what hormone?
Progesterone.
Now it's progesterone. This is why progesterone is increased. And because of that, FSH and LH will be decreased. Why? Because progesterone will inhibit it. Okay? But this is basically what is happening. FSH causes the follicular development. Yes, please.
Does the estrogen surge also increase the FSH?
هلا هو it is mentioned that estrogen in your slides إنه it has a positive feedback on the LH. I'm assuming they are working together. LH and FSH, they're produced by anterior pituitary. So estrogen will go and it will have a positive effect. So you will see both increasing. This is why you see a slight command increase in FSH. But mainly what you need to know, according to what is written, in estrogen and LH. You get me? But yes, no, I see it here يعني ف. هلا what is happening in the endometrium? احنا هون we are preparing a follicle. Does the endometrium know if this follicle will become an embryo or not?
No.
So what it will do, it will prepare itself either way, so be on the safe side. So you will see an increase in the endometrium, what do we call this? Proliferative. Under the effect of? Estrogen. هلا then after it increased, corpus luteum is there now, okay? هلا نحن the egg was released. I have corpus luteum. Where's the egg?
Fallopian tube.
Fallopian tube. So there is a potential chance of fertilization. So I can have an embryo. The chances of pregnancy did not go away. And the uterus has hope. I can have an embryo now. But it is getting excited. So it's telling the corpus luteum, please, wait. Give me at least 2 weeks, and I will take care of everything. I'll form a placenta. I'll form something. Just wait. But please produce progesterone from now. So this is why the corpus luteum will be producing progesterone, and the progesterone will act on the endometrial to make it, what is it called? Secretory phase. It will secrete things that could help the embryo, such as uterine secretions. We know that the embryo, let's say, if it formed, it entered the uterus, it will not immediately implant. It will stay for a few days until it basically, let's say you move into a new country, you're still finding a house, right? It's still finding a house, let's say, that's roaming around. The uterine secretions will help it until it actually, gets embedded into the endometrium wall, and it will get its nutrition from there. Until then, the corpus luteum secretes progesterone, secretory phase includes uterine secretions. If this all was for nothing, it was useless, and there was no pregnancy, خلاص, menstruation. Makes sense? Okay, any questions here?
In the menstrual phase in the presentation, it mentions vasospasm of the blood vessels.
Yes.
And then leads to necrotic tissue. Like, how does it relate?
That's a good question. Because I saw it too. That's a good question.
What's the question?
Like, it's mentioned there's vasospasm of the blood vessels, and then there's necrotic tissue.
I think because endometrium sphincters, they close.
The doctor mentioned that.
So the blood vessels die and they all get shed off.
Sphincters?
Yeah.
Sphincters?
The doctor mentioned that the blood vessels close, so there's no more blood to the upper endometrium, so it just dies off, sheds off.
So it sheds off. Okay. خلاص, that's good, thank you. Hella, when I was actually looking for an answer for her question, I remembered something which I forgot to mention. You know, this is called the mature follicle is called the Graafian follicle. It's just this name, I forgot to mention it in my explanation, so let's keep that in mind. Hella, everything we explained here is summarized here, okay? Follicular phase is growth of follicles, and the luteal phase is growth of corpus luteum. Hello? Main end product of the follicular phase is the Graafian follicle, which is, we know a structure, the thing which we mentioned, there's antrum, and then this is important for you to know, if not for the final, for your OSPI, it is required. LH surge causes ovulation, it's the only point where we have positive feedback from estrogen to LH. Corpus luteum produces progesterone in response to LH and FSH. LH and FSH rise. In response to that, the corpus luteum started producing progesterone, and then we had the inhibition, the negative inhibition, okay? So hence the luteal phase coincides with the secretory progesterone phase. And estrogen and progesterone, they will produce an inhibitory effect on the anterior pituitary, which is why we see that when they increase, the others, they drop. Does it all make sense? Okay. But which hormone plays a critical role in exerting a positive feedback? Yes. Anterior, yes, exactly. Recall that it usually should have a negative feedback. Exactly. Hella, over here, this part of the presentation is just to talk about two things, inhibin and activin, because they are produced by granulosa cells. Activin will, activin, it's activating, so it has a positive effect on the anterior pituitary to cause more FSH and LH to be produced, but inhibin will have an inhibitory effect. And is there anything? Yes. It also shows you that the FSH, once it acts on the granulosa cells, the granulosa cells can use androgens to produce estrogen, and the estrogen can also act. So this is how it shows you, when we said the granulosa cells, they are producing estrogen, and estrogen is going into the antrum. But this is also showing it that it is happening under the effect of FSH. And it is showing you also that LH can act on both theta and granulosa, but FSH can only act on granulosa. Any questions? And I think we covered this part. We also know that there is a negative feedback inhibition from estrogen on the hypothalamus, and this is how it also inhibits the whole axis if I have more estrogen and so on. Before puberty, this is more louder, let's say. So the anterior pituitary is more sensitive to this inhibition. Hence why puberty doesn't happen, because it's listening to the estrogen progesterone too much. Once puberty happens, it's like, I don't want to listen to you anymore, I'm going to produce my own axis and I'll cause puberty. But this is one of the reasons why the hypothalamus is also inhibited pre-puberty. Okay, reproduction lecture is done. Any questions on the reproduction lecture? Okay. By the way, this is revision, فأكيد not all details have been mentioned, so you still have to review the lecture. هلا physiology of conception. We did ovulation. We saw it in the physiology of reproduction, right? Ovulation happened because of the surge of LH under the effect of the positive feedback of estrogen. We did all of that. Ovum is expelled into the peritoneal cavity. It will enter the fallopian tube because of the cilia under the effect of estrogen. We did say this. And it's moving towards the cavity of the uterus. Okay, and we think it's clear. This is basically the ovum, just for you to see it, with the corona radiata and all. How does sperm reach the ovum? What we are saying here is how the ovum, it left the ovary, it's now in the fallopian tube, and it's going to go to the ampulla, which is the widest part of the fallopian tube, and it's the location of fertilization. How does the sperm reach there? They are entering through ejaculation. So they will enter the cervix, the vagina, and they will go all its way. They are trying to go to the fallopian tube. And they can sense the ovum by chemical, I think we took this back in foundation, so chemical temperature, yes, chemical and temperature, exactly. So it knows that the egg is there, it's trying to make its way to there. But then we said there are some obstacles that the sperm is facing, which could lead to so many of them dying and then only one making it, such as acidity of the vagina, because we said the semen is around 7.35 to 7.5 pH, so it prefers an alkaline solution, but acidity will kill it. Immune system, non-receptive mucus, and uterine secretions, a lot of things will come into its way, which would prevent it from reaching the ovum. But then, once it reaches the ovum, after it's basically struggling. So imagine the sperm struggling to reach. So it will not take care of what if, for example, it can lose its cap. This is why capstation is happening, because it's like pushing its way through. But a lot of things will leave, basically, cholesterol cap and so on and so forth. This is called capacitation. This is the beginning of what we said, the second maturation phase. The first one happened in, and this is the second one, right? And we said that the sperm transport is supported by contraction of the uterus and the fallopian tubes. We have the prostaglandins in the semen that help that, and also oxytocin from the posterior pituitary, not the anterior. Anterior FSH-LH and oxytocin posterior. But they are all supporting the sperm transport until it reaches the egg, and once it reaches, fertilization takes place. We have the corona radiata. There were two enzymes that will digest this corona radiata to enter. What were they called?
Highly proteolytic enzyme.
Yes, exactly. And then it enters. So sperm binds to the zona pellucida, and then we have the contents of the acrosome, which you just mentioned, the enzymes. They will be digesting it, and they will enter. Once the nucleus enters, with there is fusion of the two nuclei, this is called fertilization. After that, what will happen? Pronuclei will form because the nucleus will basically increase in size, and then you get the zygote. The zygote, till it reaches the uterus, this is all happening in the ampulla. Until it reaches the uterus, there will be a few days, 3 to 5 days, and it will take until for it to reach the uterus, and during that time, it's getting its nourishment from the
Uterine secretion.
uterine secretions was in the uterus before implantation. I think there was something else in the fallopian tube.
No,
No? I will check.
it was the uterine secretion.
Uterine secretions, okay. Yes? Did you say-
Secretions in the fallopian tube.
Yeah, okay. So it's still the secretions, the same thing. Okay. So it takes a few days till it reaches the uterus, and then in the uterus it will take a few days until it gets implanted. Meanwhile, division is happening. But what type? Mitosis.
Mitotic.
Yes, not meiosis anymore, it's mitosis. So it will increase in cell size and so on, and that's it. Transport is happening by the ciliated epithelium, contractions of the fallopian, and the fluid current. Ah, yes, I wrote it here. Nutrient is being obtained from the fallopian tube secretions. Okay. Implantation, in foundation we took details how implantation happens with trophoblast, syncytial trophoblast. I was happy to not see all these details in your slides. Alhamdulillah, you don't need to know.
It's an embryo.
Hey, Allah يعينكم. Good luck. You will take this in the Thursday Pacademia session, inshallah. Anyways, but you need to know, they mentioned the trophoblast will form, embryoblast will form. Trophoblast has to release proteolytic enzyme for what? To embed inside the endometrium. That's all the details mentioned in physiology, alhamdulillah. Okay, then placenta forms. Placenta basically is what is connecting the baby to its mom, and the placenta also produces hormones such as, very important one, HCG. What does this do?
Keeps the corpus luteum alive.
Yes, because if the corpus luteum dies, miscarriage. Placenta also has a role in hormone production, and it's connecting the baby to the mother to get its oxygen and its nutrients and so on. You have the umbilical vein and umbilical arteries, and this is one of the exceptions where you see the artery taking deoxygenated blood from the baby to the mom. Vein will take oxygenated, and that's it. We have hormonal factors during pregnancy. We said that this is ovulation took place in what? The second week, because technically 14 days they were follicular phase. Ovulation took place and then luteal phase, right? So in the second week of the menstrual cycle, so 2 weeks from the last menstruation, ovulation took place. Around 2 weeks later, in the slides it mentioned 12 days, the placenta, not the placenta, sorry. 2 weeks later, HCG will start being produced. And then from the trophoblast, yes, from the trophoblast cells, because they're going to be produced after, they will start producing HCG after 12 days, so that it can maintain the corpus luteum. And then once the placenta forms, which is around, I think, between the 20th and the 24th week, the placenta is formed. That's when it takes over this HCG production, because, and it will continue basically producing this hormone.
Placenta more third month or fourth.
Third month,
And it
yes.
doesn't produce HCG. It produces the main hormones itself.
Main hormones itself.
Yeah, so the corpus luteum after
So,
placenta.
corpus luteum is producing progesterone. HCG is maintaining it. Placenta will produce progesterone. We don't need corpus luteum anymore. The corpus luteum will be degenerated.
It produces both hormones.
Progesterone and estrogen. Thank you for thank you so much. So HCG trophoblast prevents involution of corpus luteum. At least 10 weeks until placenta. So you are right. It's 3 months because 10 weeks approximately. That's when the placenta forms. Estrogen. It is also produced by the ovarian follicles, yes, which is the granulosa cells, the corpus luteum itself, and then the placenta. And the progesterone, same thing. Estrogen, you need to memorize everything: growth, proliferation, estrogen. Progesterone is more about secretions. So if you see stimulates growth, enlargement, everything enlargement is estrogen. Progesterone, it has 2 things very important: decreases contractility of pregnant uterus, because we don't want contractions to happen. Now the pregnancy is still happening, we don't want it to contract, and it's preparing the mother's breast for lactation, not by enlarging the ducts, but by helping it develop to become secretory. So it secretes the milk. Okay? هلا if the fetus is male, this is from your notes, testosterone is released under the effect of HCG, which is very important in development of the male genitalia. It's also important to keep in mind. Okay. How to diagnose pregnancy? I like the diagnosing part. So you have history taking, physical examination. History taking is asking the patient questions. Did you guys start history taking asking?
Yeah.
Okay.
That's good.
Physical examination, of course, from the very important things which you'll be focusing on, other than the signs and symptoms such as nausea and vomiting and all of that, changes in appetite, you'll also be looking at her menstrual cycle. Ask her when was the last time you got your period and so on. These are some questions which you have to ask. You have ultrasonography. There are two types: trans-abdominal, trans-vaginal. Abdominal is more common. Trans-vaginal is usually avoided. Lab evaluation. What is the main hormone we are looking at? Bravo. Very quick. So now we have changes during pregnancy. Physiological changes. They're not pathological. There are lots of things. مثلا you take in physiology. This is abnormal to have this heart rate. It's abnormal to have this cardiac output. But then you say, but exceptionally, it is physiological in pregnancy. But these are the organ systems that could be affected or مش affected. يعني they will adjust to the pregnant situation. Why do you think so? What brings these changes to happen?
The fetus, like the changes in the fetus of the blood and everything.
Like what energy requirements.
Energy
she needs to-
requirements and hormones.
Yeah.
Hormones. Yes, what you said is also correct. Yes, أكيد. So circulation, metabolism, and hormonal production. تمام. Let's look at them. I started with endocrine. I changed شوي the sequence of the slides because I feel like starting by endocrine makes sense. Everything else is dependent on. You have increase in all of the hormones. Corticotropin, thyrotropin, prolactin. Prolactin is very important to increase, but it's inhibited. It will not actually produce milk until
Birth.
birth. because-
Suckling.
Progesterone levels drop.
Yes, exactly. Aldosterone, pyroxene, and all of that. Aldosterone, do you remember what it does from foundation?
Yeah. Water volume,
Absorbs
sodium,
sodium.
potassium.
Exactly. Okay, so it's increasing the blood volume, fluid retention. This is brought about by aldosterone. And the cardiac output will increase. Why? Because
Because it feeds the baby also.
yes, we want to double the amount of blood. Why do we want to double the amount of blood?
So when she gives birth, when she loses blood, she doesn't like go.
It's a safety measure to
Yeah.
protect the mother. Exactly. هلا احنا cardiac output you take انه it is equal to stroke volume times heart rate. Both of these are increasing, so by default cardiac output will increase. And then you have the heart shifts up and to the left. Increasing respiratory, again respiratory rate will increase, minute ventilation will increase. كل شيء زيني increased. هلا كمان you need to know that there's increased sensitivity in the respiratory center to CO2 under the effect of progesterone. Okay, metabolism. We have weight gain, and it's mainly in the last 2 trimesters. This, what do you call it? This table which you have, I remember the numbers were not to be memorized, but the concept. So over here you have an underweight woman who got pregnant. She has to try to gain a lot of weight. The normal for her to gain is a lot of weight. So if you see a woman that was underweight, she comes to the clinic and she tells you, I gained 17 kilograms and during pregnancy, this is fine. But if a woman is already obese and she tells you, well, she's gaining 17 kilograms, this is abnormal. That's basically telling you that depending on her state pre-pregnancy, you will know what is the expected normal range for weight gain. And also the genital tract will change, of course. You have enlargement of the uterus, especially in the fundal area. You know what's the fundal?
Yeah, the top.
The top. It will increase in the beginning, it will thicken. Towards the end of the pregnancy, you will start seeing it becoming very thin. And there's increase in vascularity and hyperemia of the vagina, perineum, vulva, and also the cervix will soften and it will be, there will be increased vascularity. All preparation for birth, basically. Tamam, urinary system. Your rate of urine formation is increased. Reabsorption of this because of the hormones. Renal blood flow is increasing, which is why GFR will increase, and then you have renal vasodilation. Everything will, until now, everything is increasing. We didn't see a lot of decrease in anything except هلا you will see it. GIT, energy intake will increase, obviously. Acidity will increase, which could lead to, it comes here. It will lead to heartburn, gastric reflux. Nausea and vomiting will also, I think it's very well known in pregnancy. Something will be decreased. Smooth muscle tone and motility, which could lead to constipation. Why?
Baby is pushing against the GI tract.
So it doesn't expel the baby early.
Mm-hmm.
Peristalsis.
Peristalsis. Okay, think of something hormonal. Something you like. Yes. Progesterone. We said, I think, here. Decreases contractility of pregnant uterus. It also decreases the contractility of smooth muscles. It's not in the table, but it is mentioned. Progesterone will decrease the contractility of smooth muscles, so this will also have an effect on the GRT.
What's the benefit of doing this?
Is there a benefit, Naya, for doing this? Progesterone decreases smooth muscle contractility. But this is why you have constipation in pregnancy. Is there a benefit to do this?
Yeah,
What?
protective mechanisms.
Mm.
Not progesterone, right?
Mm.
As far as I remember, progesterone, was it progesterone that is kept silent during the delivery?
Progesterone, it's increasing in pregnancy. It
Yeah.
decreases smooth muscle contraction in the uterus and also in the GRT. So what is the... Yeah.
Because basically the whole body is trying to protect the baby until the baby is mature to be delivered, right? Baby illness. So until the delivery, you need to keep the muscles calm so they don't try to kick the baby out before it's the right time for the baby to come out. Get it? So basically, when it's time for the delivery, that's when the pelvic muscles of the females, they become much stronger. There's a lot of chemicals, neurotransmitters, a lot of stuff are released. Everything's going on just to facilitate this delivery process. However, before that, for 9 months, the baby is a foreign object in the woman's body, right? So if you don't suppress or if you don't calm down the muscles and you suppress the immune system and all that, it's going to keep on trying to actively kick it out of the body, get it? So this is why the muscles usually are calm under the influence of progesterone during the pregnancy itself to allow the baby to grow until the delivery time. If that makes sense.
Thank you. Thank you, Naya. Okay. Breast and lactation. Okay, we have increase in size of the breast itself, the nipple size, the areas, they darken, and we have production of colostrum. You know what colostrum is?
Yeah.
The first, before basically milk is being produced, so the first milk that is produced, it's called colostrum, it's more yellowish, but then it becomes the normal milk. Fair. Hello, what drives these hormone changes? We said that. Okay, what drives these changes? Hormones. We agreed, the hormones, they are acting on all of this, and so we are looking now during pregnancy, and I'm specifically talking about breast and lactation here. I'm not talking about the physiological changes, but during pregnancy, why is this change in the breast happening? The estrogen, as we said, growth and proliferation of the ductile system. Progesterone will stimulate the development, as in becomes secreted, it will learn how to secrete milk, basically how to produce it. Placental lactogen promotes the development of the breast, so also placenta is contributing. And then prolactin, I think you guys already mentioned this, in the mammary gland development by introducing synthesis of enzymes which are required for milk production, milk synthesis. We are producing the milk by prolactin. What is the oxytocin doing? It's more of the mechanical. But prolactin is more of the chemical actually producing the milk, but the milk is not yet ejected, but the oxytocin is what ejects it, صح? And we know that the prolactin is inhibited by placental hormones. I think your colleague mentioned estrogen and progesterone. After birth, estrogen and progesterone, they will drop. So now the contractions happen, the delivery is done. Prolactin is no longer inhibited. The milk will be produced, and mechanical stimulation of the breasts by the suckling of the baby and also by the oxytocin. Oxytocin stimulates the release of milk from the ducts using the contraction of the myoepithelial cells that surround each alveolus. And when breastfeeding is continuous, prolactin is produced. So this is why the suckling of the baby is very important, because it will, the suckling has there are mechanoreceptors in the nipple. They will stimulate the hypothalamus to produce more oxytocin, produce more prolactin. So milk production continues, and also milk ejection continues. This is it. So this is why the milk needs to be, this is why the suckling is important, and they're basically talking about that. Once a baby stops breastfeeding, at some point the milk will also cease. A medical student asks the obstetrician about the mechanism of suppression of breast milk production in a pregnant woman. What is most likely the cause of this phenomenon? Inhibition of prolactin by placental hormones, suppression, inhibition of prolactin by fetal hormones, reduced production of the placental lactogen. Yes. Okay. Physiology of puberty, last lecture. First part, it starts by talking about the growth spurts. Yes?
Can you go back to the question? Why is it there?
Why is it A? Okay, so we went and we said prolactin, action of prolactin is inhibited by placental hormones which are estrogen and progesterone. Once these drop, there's no more inhibition, prolactin can actually act, so this is why after childbirth, the mother can produce milk. She can't do that during pregnancy. Is that clear? Why we said placental hormones? Okay. Any questions about pregnancy, conception? Did I confuse you at any point? Physiology of puberty. The lecture starts by talking about growth spurts. Like we know that there's a growth spurt happening during puberty, but there's also a growth spurt following birth in the first year of life. There is an increase in height, there is an increase in weight and head circumference, which are very important to monitor during that first year. And I'm not sure if you'll be taking a pediatrics lecture, but we had that in life cycle. There was a whole lecture about the developmental milestones of a baby. The height that is expected, within the first year we are expecting. It's a beautiful lecture. I love that lecture, very, very nice. So that is monitored during the first year. And how do we monitor it? And when the baby goes to the clinic and they measure the height and the weight, they are comparing it to a standardized graph. And these graphs are very important. And it has a graph for girls, for boys. This is the age, this is the height, is this normal? Okay, this is the percentile. So the doctor can look and evaluate, is this baby growing as it should be? Oh no, he's a bit delayed, he's a bit too quick. And this is a very important graph. We even get it in OSCE and everything. So yeah. Okay, so we need to know the postnatal growth, which is the first year. It's only somatic. So the body is growing, but ما في reproductive growth. In the puberty, the difference between these two, now you have somatic and reproductive. So now you are the reproductive organs. This is puberty. The person can now has the ability to reproduce because the HPG axis wakes up. Remember, if we mentioned in the beginning of the session, there is inhibition of the negative feedback inhibition of the estrogen and progesterone on the hypothalamus. This is louder in this phase of life. That's when puberty has to happen. It becomes the axis wakes up and it's like, okay, you don't have to inhibit me the whole time. I'm gonna wake up, I'm gonna do my work. Did you want to ask a question? Okay, and then the product of the, yes, this is the very first question in the very beginning of the lecture, when we said it's all interacting. So it's the product of complex interaction between gonadal sex steroids, estrogen, testosterone, growth hormone, and insulin-like growth factors. When we mentioned the dwarfism and all. Puberty. It's the second growth spurt, and it is the maturation of the primary sexual organs, which we said testes and ovaries, appearance of secondary sexual characteristics, and it's the initiation of spermatogenesis in boys, which usually happen 9 to 14 on average. Puberty in boys is 9 to 14 years. Menstruation in girls, which is usually 8 to 14, and this basically marks the puberty. The onset can vary, of course. The onset can vary. Hey, it's one slide in your lecture. And it's very messy. It's basically telling you there's environmental factors that could affect when girls could get their first period, for example. The temperature, the geographical location, the food they're eating, the genetics. A lot of things can affect. So basically, the onset can vary. This is why it's a wide range, but we have an average. And this is, I think we went over it when we were talking about the reproductive. We have the hypothalamus, we have the anterior pituitary. The GnRH will act on it, produces LH, FSH. Goes to here we're looking at the main reproductive system. The testis, Leydig cells will produce testosterone, and we said that it also has inhibin. We said inhibin and testosterone has a negative effect. Makes sense? And same thing happens here. Estradiol is estrogen. When I actually looked it up, it's the same thing. It's just synonyms. And one more thing which we want to know over here is they brought up something called neurokinin B and KIS1 neuron. And they basically mentioned that these also activate the GnRH release to also initiate this axis. فمثلا hypothalamus gets activated by kespertin, leptin, in addition to these three things. اللي هو amygdala of the limbic system, decreased hypothalamus sensitivity to gonadotropins, which we brought up when we said that the sensitivity decreases when puberty has to hit. This is the second one, this is what they mean. And lower levels of melatonin. Melatonin is higher in children, which is why hypothalamus is inhibited, and this whole thing doesn't happen, and puberty doesn't happen earlier. فكمان, if there's a problem with melatonin, it could also affect this axis. It could lead to some issues with puberty. And yeah, any questions? Okay. Hello, over here we have hormonal changes in puberty. Basically when the GnRH goes to the anterior pituitary, we know that it releases LH and FSH, and I'm not going to repeat that. I feel like we memorized it enough. And we know that it will lead to a lot of things, testosterone, estrogen, secondary sex characteristics, and gametogenesis. We also have the growth hormone being released, which is induced by estrogen, testosterone. It has metabolic effects. I think we also mentioned the growth hormone is also essential for the beginning of spermatogenesis. This is why we mentioned multiple pituitary dwarfism and how it could affect infertility. Am I too quick?
No.
Okay. But then we also have an increase in TSH and ACTH, and all of them have their own, let's say, functions which could also aid puberty, such as more metabolic rate, more tissue growth, because we have a growth spurt, I need more tissue growth. So everything happens, a lot of glucose uptake for the increased energy requirement during puberty and so on. Hello, we have puberty events. You have these 5 events. What is stellarchy?
Enlargement of the breast.
Breast, yes. Menarche is the menstruation. Adrenarche.
Hormones.
Adrenogens.
Adrenal glands. Pubarche. Pubic hair, yes. Gonadarche.
Enlargement of the gonads.
Yes. Okay.
Enlargement
Of the gonads.
Yes, exactly. Females, the first thing that happens is the breast. So it's which one we said was the breast? The first one. So this is the first one in females, but in males, the first one is actually the gonads, the testicular enlargement, and then the pubic hair and the penile growth. Females, they start with the breast, and then the pubic hair, and then the menarche. Okay, this is the order. You have something called the tanner, right? So the tanner, I actually wanted to know like what is exactly required from you to know. All you need to know, no, there are stages. It's gradual, right? Like if you look at the tanner stage 1, 2, 3, it's all gradual. You will not get a picture in the exam showing you, مثلا, this is the state of the breast or this is the hair growth. Which tanner stage is this? They will not ask you this way, but they can tell you, a girl, she's 7 years old, she's at tanner stage number 3. This will tell you that there's something wrong. It shouldn't be at tanner stage 3 when she's only 7 years old. So it's just for you to have an understanding. Also keep in mind, in foundation year, مثلا, we had the book. This book was, خلاص, we go by it, everything that's in the book could come in the exam. In year 1 onwards, because now you're being treated as doctors, they will put things in the slides, not necessarily for exam purposes, but for you. Imagine going to a hospital. I studied physiology of puberty, but I don't know what tanner stage is. Doesn't make sense, because tanner stage is used in clinics to look at the hair. A lot of things, so I just wanted to bring that up for you, and try to have a good understanding of the topic, not just for the exam, for you to understand, and then when you understand the topic as a doctor, exam things, they'll come by default, this is a question just to revise these 5 terms. So a 10-year-old girl presents with early signs of breast enlargement. No pubic hair. Which stage? C. Yes. Okay. A 9-year-old boy is noted to have increased body odor and early axillary hair, but his testes are still preview. Adrenarche, exactly. And then 12-year-old girl presents with development of coarse pubic hair, axillary hair. Yes, bravo.
Wait, can you shouldn't it be both pubarche and menarche? I mean, pubarche and telarche. There's also
presents development of coarse pubic hair and axillary hair following breast development. Which event of puberty does this represent? You are right. So telarche already happened. She is in the pubarche phase. I think in the question we are referring, what is she doing?
It goes in an order, like we have to know the order.
The order in your slides, this is mentioned. I took this from the slides, and in females it starts with breast budding, which is telarche, followed by pubic hair, and then menarche. In males, they mentioned this order. Yes, it could happen in order, it could happen together because one leads to the other. Makes sense, صح? I think adrenarche
is independent.
Adrenarche is independent, it's true. Yes. We will look into the schema. It came. Perfect.
So check the second question.
Yes. Okay. This one?
No, this is adrenarche.
Adrenarche.
So why not puberty?
Increased body odor and early axillary hair.
There's no pubic hair.
Pubic hair is pubarche. You get me? Yeah?
But it's written in the PowerPoint axillary and pubic hair.
But maybe because puberty will be in following the order of events,
Yes.
but adrenarche happens independently. So.
Because yes, pubic hair, it follows testicular enlargement. I think they are connected technically. But yes, thank you for also bringing it up. Puberty could also involve axillary hair. So
It does come.
We didn't do the last question.
you didn't do the last question? It was testicular enlargement, rise in testosterone levels. What pubertal event does this involve?
Pubic and axillary hair.
Yes,
So
in check.
this question, we have to stick
Development of
Yep, gonorrhea. Okay. هلا adrenergy. Awakening of the adrenal gland, increasing in the production of adrenal androgens, such as the ones mentioned. This is mentioned to be very significant biologically, and it is independent of puberty, as your colleague mentioned. It could happen in the age of 6 to 8. It is stimulated by these hormones. It's stimulated by STH, estrogen, prolactin, and so on. A lot of things could awaken the adrenal gland, and it would result in secondary sex characteristics, okay? And that's it, the adrenal glands on top of your kidneys. That's pretty much it here. It's a very messy slide. I just tried to make it a bit organized. Testosterone. In pregnant, while the child is in his mother's womb, there will be a surge and there will be increased testosterone. I think we looked into it in the physiology of conception, and we said that it's important for the male genitalia to be developed. And then it will also, at puberty, you will start also increasing it more, and at adulthood it will be high. But like in childhood, the testosterone will be low. Once it is increased the levels at puberty, you'll see the secondary sexual characteristics such as the voice change, muscle development, the BMR will increase, and everything. هلا male pattern baldness is a bit later in life, so يعني at puberty مش ضروري الولد يصلى، يعني this will happen a bit later. ومش ضروري it happens كمان عادي. Now estrogen. Okay, estrogen will also increase in puberty. There is this reproductive, we call it the reproductive window, when a woman can reproduce. But then menopause happens. Post-menopause estrogen is low. It's a bit different than testosterone. صح? Has effects in addition to increasing size. Why did I say this? I know everything. When they were talking about the effects of estrogen on these organs, increase in size. I just said, in addition to increasing size in the ovaries, it starts the menstrual cycle. In addition to increasing the size of the fallopian tube, it increases the activity of the cilia. We looked into this when we said ovulation happens. It will pick up the ovum, yes. Uterus prepares it for welcoming the fetus. Vagina epithelium changes from cuboidal to stratified. Why?
To have goblet cells?
No, for implantation.
لا, vagina.
Oh, okay.
Yes. Cuboidal to stratified, the reason it's more protective, right? Because during this reproductive period, the vagina يعني there is menstruation and there is also sexual intercourse. فهي to protect the vagina we do this, okay? Memorize in the estrogen stratifies and acidifies. It makes the vagina more acidic. It makes it stratified. Acidic. This is something Kaman you will learn later. I think in man and his environment, there are microbial flora. We have in our body we have bacteria that is helpful for us. But there is a certain bacteria in the vagina. It will make it acidic, and it has its own benefits. Yani you will learn it when the time comes, inshallah. Breast. We already took development of the stromal tissue. Ductile system will grow, and then there will be deposition of fats. And yeah, so we have effect on the bone. It inhibits osteoclastic activity, which is protective. But after menopause, there is high risk of osteoporosis, which is the bone density will be lower. So yeah, as long as the estrogen is high, it will maintain bone mineral density. It promotes epiphyseal closure. This is why mostly females, when they hit puberty, the height, it will stop. Like their height will be maintained at that stage, خلاص. And then effects on metabolism, increases body metabolism, increases fat deposition, particularly in the hip and thighs, which is the female body shape, and effects on the skin. It maintains smooth and youthful. I saw this in the lecture, but I don't believe in it. I don't see this. Okay, an 80-year-old postmenopausal woman that with a broken hip was found to have low bone mineral density. She was prescribed a hormone that shares similar action with estrogen. Which of the following is a possible mechanism for these findings? B. Do you think it's B?
Shouldn't be inhibit osteoclast.
Okay, but increase osteoclast activity. See?
Similar action with A.
You think it's A?
Yeah.
Can you explain why you think it's A?
We mentioned that in the previous slide.
Okay. We mentioned, as he said, inhibit osteoclast. Do you think it's a typo? مثلا?
Yes.
You think it's a typo? It's not a typo. It's correct. It is A, and I'll tell you why. لأنه postmenopausal, and they're saying that she was found to have low bone mineral density, and they're saying, why is this the finding? They're not asking about the mechanism of estrogen. You get me? And yes, it's a tricky question. I agree with you. She was prescribed a hormone that shares similar action with estrogen. They're not asking what estrogen is doing. They're saying, why does she have low bone mineral density? Because there's increased osteoclast activity because the estrogen is not inhibiting it anymore. Do you get it? Yes. progesterone ماشي. It has secondary sexual effects as we know. على fallopian tubes, more secretion from the mucosal lining. Why? Why do you need more secretions in the fallopian tube?
To feed the zygote.
Yes, exactly. Uterus decreases frequency and intensity of uterine contractions, plus the secretory phase of the endometrial cycle, which we already know, and breast development of lobules and alveoli of the breast. Any questions? Clear, صح? Okay, هلا apply to clinical. This is the last part of your puberty lecture. We are just looking at what we learned in puberty to apply it in a clinical point of view. But we have some diseases which we want to know. There are a lot of diseases which you might look into in a genetic lecture. هلا in your physiology, this is what they mentioned. So they have early puberty or delayed. Early has two types, delayed has two types. In early, and the true, let me try to pronounce it guys. Precocious puberty. خلاص? Can we say early? Early حلوة صح? Okay, so true early puberty and the pseudo. So the true is related to what?
Pituitary.
Yes, the central axis. مش كبس central. In the pseudo, the problem is not in the central, the problem is in the gonads. Delayed puberty, you have hypogonadotropic hypogonadism. هنختصرها to say hypo. And you have hypergonadotropic hypogonadism, hyper. Okay?
I have a question.
Yes, please.
I didn't get the early period. يعني why does it happen?
Early puberty. هلا we will explain exactly why early puberty happens.
Tumors in the
Yes.
cephalic regions يعني.
Yes. اللي هو tumors that could happen in the brain that could lead to gonadotropin release.
Cranial lesions.
Yeah, cranial lesions.
Yes. كمان it was mentioned in the early is more common in females. The delayed is more common in males. Just know it يعني. Yes. هلا let's look into this. هلا I think هون I just want to look into the central axis and all. Anterior pituitary releasing LH and FSH under the influence of GnRH صح? These will act on the gonads. هلا why can I have early puberty? Because مثلا I have more GnRH. It is يعني excessively being produced, so more LH FSH, more estrogen testosterone. So earlier puberty. This is the true early puberty, GDPP as in gonadotropin dependent. It is dependent on the levels of GnRH. But when it is not dependent on it, everything here is normal, but these are the estrogen and testosterone are very high. It could be due مثلا to being secreted by adrenal gland. صح? Adrenal gland also produces androgens, so it could مثلا abnormally secrete too much, leading on the last part maybe. Okay? فيا GTPP, early maturation of the axis at the center. It is dependent on gonadotropin. في عندي early dermatogenesis, everything is happening early. هلا puberty levels of hormones including FSH and LH. So like a 6-year-old boy, you find FSH and LH as like the levels, they look as if this person is in puberty and this is abnormal. The FSH and LH will be high. Okay, and causes intracranial lesions, gonadotropin secreting tumors, or it could be idiopathic. Okay, looking at GIPP caused by excessive secretion of sex hormones, اللي هم estrogens or androgens, and the source could be from the adrenal gland. It could be from the gonads themselves. Okay, or it could be exogenous. هلا هون you have FSH and LH, they are low, they are normal يعني, they're not increased. And even if you administer GnRH, how is this?
They will stay low.
Yes, because the problem is not in the central. I'm giving GnRH, okay, but this is not going to affect anything. So this is how you differentiate. You have a child with early puberty, you give them GnRH and you measure their FSH and LH to see will it respond to this GnRH or not. Okay, but this is what's mentioned here basically. And now delayed puberty, we have it was mentioned in 3 cases where I can say this person has delayed puberty. 2 of them are concerning with females, 1 of them is in the male. The females, at 13 if there's no breast development, at 15 if there's no menstruation. For the guys, if by the age of 14 his testicular size is less than this or the volume is less than this, then we can say okay, he's also delayed. هلا hypo هي hypogonadism, شو كانت hypogonadotropin hypogonadism, that's the full form صح? Hypo I have gonadotropin deficiency, so I have less FH and less LH. Makes sense. خلص less من هاد less من هاد. Here I have hyper, I have high GnRH, so it's fine. But gonads are not responding. So I have high GnRH, high FSH, high LH, gonads are refusing to respond. But the puberty will not happen. And in both ways I will have low sex hormones, اللي هو low estrogen and testosterone. Okay? What do you think are the causes of each? And this I think will be the end of my part for now. The causes of hypo and the causes of hyper.
For the hypo, I think it could be problem the pituitary itself. If there's a tumor blocking the pituitary.
Okay.
And the hypo, it can be something blocking the gonads themselves.
Okay. So blocking that, when you said hypo blocking the pituitary, yes, it could be a brain tumor or anything that's happening. It cannot release gonadotropin. It could be due to endocrine causes, malnutrition, and so on. And for the hypo, it could be damage due to
Trauma.
chemotherapy, radiation, and I think chemotherapy and radiation is, I feel like it's high yield لأنه this is the I came to year 2 and I wanted to prepare for the Pacademia. For some reason that was the one info that really stuck to my head. في chemotherapy this happens. So I think it's something that really the doctor focused on لدرجة إنه أنا هلا عالقة براسي يعني. Or maybe it was just traumatizing. And I think that's it. We just have a few questions. A 14-year-old male who was late in hitting puberty was diagnosed with hypogonadism secondary to the failure of the HPG axis.
B.
He was started on testosterone. Yes, I think it's B. صح.
Can you please read the question?
Everyone agrees it's B ولا I didn't. That's bravo. Yeah. Testosterone in early puberty stage will cause an increase in height. We know we said that it will increase bone density, and usually أصلاً at puberty there's a growth spurt. There is increase in height. But why do we say there's premature closure? Because later on it will start closing the epiphyseal plate. Because if it's always gonna continue growing, you will still continue growing until 40. It's not gonna make sense. So there's a growth spurt and then it stops. But this boy is 14. Okay, at a very young age, you're giving him replacement therapy, and you're giving him high doses of testosterone. It reached the inhibition phase directly. So this is what happens. Okay, a 7-year-old girl presents with early breast development and pubic hair. Her bone age is advanced. Laboratory results show elevated LH and FSH that further increase after GnRH stimulation. What is most likely the diagnosis?
B.
Elevated LH and FSH because of
Sorry.
خلص don't say hello, you answer. An 8-year-old boy presents with early development of sorry. Technical issues. So with early development of secondary sexual characteristics, his serum testosterone is elevated, but his LH and FSH remain low even with GnRH stimulation. What is the mechanism behind this condition?
B.
If we look at C, pituitary adenoma secreting gonadotropins, what is this condition?
The opposite.
Hyper.
Hyper.
No, hyper.
Pituitary adenoma secreting gonadotropins. هلا انت hypo is delayed puberty. And هلا انت secreting gonadotropins. Yeah. سودو صح؟ It is pseudo, right? ولا أنا مخربطة؟ Because شوي شكيت بحالي بس لأنه you have an adenoma as a cancer, adrenal gland, أو لا pituitary, sorry, this is in a pituitary. You are secreting gonadotropins abnormally. Puberty will take place earlier. And
Hi guys, this is Naya from year 3. It's okay.
I have the dialect.
No, it's okay. And I'll be explaining all the physiology that is included in your mid-unit that is related to the CVS, okay? Okay, so first we want to start with the basics, all right? So this area would be your systemic circulation. This is where your body tissues are receiving the oxygen and they're getting rid of the carbon dioxide, right? So from here, you have what? Deoxygenated blood, right? And then it's gonna go into the right side of the heart. It's going to be pumped into the lungs to have the exchange happen. And once the exchange happens, you're back to having oxygenated blood again. All right. So I just want to go through the real basics. I know you covered this in foundation. Okay. Now the main functions of your cardiovascular system is to deliver oxygen and to remove carbon dioxide, which makes sense when you look at the whole cycle overall. Now, just an overview. arteries, they deliver the blood, and the veins, they take the blood. Okay, so arteries, they push, they propel the blood, veins, they store the blood. Okay, so now we're going to start building up from here. Okay, so now you have the heart. It has received the oxygenated blood after the exchange from the lungs, and now it's going to pump it back into the organs, right? Okay, this pumping out, or this outcome, is going to generate what we call the cardiac output. So this is the output of blood that you're having from the left side of the heart, okay? Then, once the exchange happens at the body tissues, so the body tissues are receiving the oxygen and they are getting rid of the carbon dioxide, what do you think happens after that? Now you have blood carrying carbon dioxide, but the amount of blood itself, the amount is still the same. But this is what we call the venous return. So I'm starting from the very basics here again. The main point that I want to deliver in this slide is that venous return is equal to the cardiac output. Okay, so that means that the output or the outcome, the output of the what the heart is pumping is going to be equal to the amount of blood that is going to come out of the body tissues after they're done with the exchange. All right. Now, this is at a steady state. This is at a steady state. So, looking at this question. What happens if we suddenly increase the cardiac output, like when we start running? When you start running, you took this in foundation, up to some extent, your skeletal system needs an increased amount of blood, right? So your heart starts pumping faster to pump more blood. The cardiac output is gonna go up, right? So what is going to happen to the venous return? It will increase, because they are equal to each other, okay? So once you start running, the moment you start running, the output is going to be increased. Momentarily, for a very short moment, the output is going to be higher than the venous return, but then the venous return is immediately manages to become equal to it, okay? Is that clear? Okay. Now, here, I want to explain the difference between the systemic and the pulmonary pressure. So pressure is the driving force of the blood, right? Do we agree on this? Now, where would you see higher pressure gradient? In the systemic or the pulmonary circulation? Systemic. Why is that?
Because it delivers blood to the whole body.
Okay, so what?
Greater pressure to reach all parts.
Sorry?
Greater pressure to reach all parts.
It needs higher pressure to reach all the parts. Exactly. And you have the distance. Okay? And you have the resistance. Because when you're delivering blood to more areas or more circuits that are parallel, which is what we're going to cover soon, you're going to face more resistance. I will be explaining resistance, okay, but just keep that in mind. And for the pulmonary circulation, which is the circulation where the right side of the heart pumps blood to the lungs, exchange happens, then the lungs pump it back to the heart, so it pumps it to the rest of the body. The pressure is slower. For one reason, which is the distance, as you mentioned. Here are the lungs, here's the heart. They're close, okay? But there's another reason. What is it?
Delicate tissue? Delicate tissue?
No. It is delicate, yes, but for the same reason that it has a lower pressure. What is the main function of the lungs? Exchange. So, for me to have gas exchange, I need the blood to go really slow to allow proper exchange between what? Oxygen and carbon dioxide, right? This is why when you start running, at some point it hurts, okay? Because you're not giving your lungs enough time to exchange the blood. So this is another reason why the pulmonary pressure has to be lower, okay? Another point I want to just quickly go over is that the systemic circulation involves all of these, okay? Thing is, different parts need different demand, okay? They have different demand for blood. And this is more clinically relevant because we have places that are considered high priority, which is what? Your brain. So, God forbid, you get involved into a car accident, you lose a lot of blood, then suddenly the main priority, you don't have enough blood to supply the whole body. So now we are in a state where we want to prioritize certain parts of the body, one of them being the brain, okay? So this is a very important idea to grasp, but don't worry, the doctor doesn't usually focus on it, okay?
Now we go to the arteries and the veins and the blood vessels in general. So, blood is pumped from the heart through the aorta, okay? Then, through the muscular arteries, it's going to supply the rest of the body, right? But right before it gets into the body tissues, or more specifically, the site of exchange, they get really small until they become arterioles. And then into the capillaries, then the venules and the veins. Why is that? First, you have the aorta. I need the aorta to be a blood vessel that has the ability to endure extremely high pressure. So it can have the ability to pump blood to the rest of the body. Do we agree on this? Okay, the aorta is done. It has thick elastic walls and it can deal with very high pressure. And it has low compliance, which is an idea I'll be discussing in a minute. Then we have, after the aorta, we have the arteries, the muscular arteries, which are you can see the branches. And then you have the arterioles. Right before we get involved into the capillaries, we have the arterioles. Why is that? The arterioles are basically your traffic control, okay? Because in the capillaries, same concept that we used in the lungs, gas exchange. So for gas exchange to happen, I need blood to move slow, right? For proper gas exchange, I need the blood to move, slow, okay? So for that to happen, I need to control the huge amount of blood that is coming at once, and that happens at the stage of the arterioles, because they're basically your traffic lights. They control the amount of blood that seeps into the capillaries. Then we have the capillaries, that's where the exchange happens, and then we have the venules and the veins and the vena cava, okay? Now, aorta has high pressure because it needs to propel or pump the blood. Push the blood. And the veins, in the very beginning, I emphasized on this, veins store the blood, right? So they have low pressure. I don't want to be pushing the blood, right? Then this takes us to another concept, which is the compliance and the capacitance. Compliance is how compliant a vessel is. Compliant. The word compliant means how easily stretchable it is, and how easy it is to get stretched. So when I'm talking in terms of blood vessels, which one would you expect to have the higher ability to stretch, higher ability to store? The veins.
Elastic.
The veins in general. So the veins in general are going because they want to store the blood, right? It's okay. And which one would I expect to have higher compliance? They're not very compliant. The moment they have the moment blood goes through them, they just push it away. The arteries in general, okay? So arteries have low compliance and the veins have high compliance. Then we have so compliance is basically the change in volume over the change in pressure, okay? And do pay attention to the gradient here, okay? Dr. Adel likes to trick you in these small areas, okay? It is the pressure gradient and the gradient of, or the change in volume. Then we have capacitance. Capacitance has a similar concept to compliance, and it is the capacity to hold blood. Basically, the ability to store, the ability to hold on to blood. So which one has the capacity to hold more blood? The veins. And again, the arteries, they just push it away. Do you understand everything so far? Okay, now here's the fun part. So here, I'm looking at the volume, okay? So from 0 up to 4,000. And here I'm looking at the transmural pressure, okay? So the y-axis is your volume, transmural pressure, the x-axis is your pressure. What does transmural mean?
Across the
Across the what?
The whole vessel.
Trans means across, that's true. Mural means the vessel, so across, the wall, across the wall, okay? So here we're looking at the pressure across the blood vessel's wall. Now, I want to compare the veins and the arteries. Let's look at the veins. So this is the normal venous and this is the normal arterial, okay? Let's look at the venous. When I increase the volume, does it shift much the pressure? Does it increase much? No. But then you have the artery. I increase the volume just a bit and there's a huge difference in pressure. This goes by what I was trying to explain here. And that the veins, they have high compliance and they have high capacitance. What does it mean? it means that a huge change in volume does not really affect its pressure, okay? While for the arteries, they're very, 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 very sensitive to this. So basically here you have a small change in the volume causes a huge steep jump in pressure. Why? Because I, as the artery, I just want to push the blood. I receive blood, I want to push it away, okay? So let's say, I don't want to go back to the same model, but the heart pumps the blood from the aorta. So you have suddenly a huge amount of blood seeps into the aorta. The aorta immediately senses this change in volume. The pressure immediately steeps, okay? Is this clear? Is this clear? So the venous system has the ability to store blood, meaning a large change in volume, only a small change in pressure. That is the very definition of high compliance, having the ability to endure a change in volume. Then you have the arterial system, the exact opposite. It does not have the ability to store blood. It does not have the ability to deal with a change in volume. So a change in volume, even if it's small, can cause a huge steep jump in pressure, okay? Now, I explained the normal venous and the normal arterial. Now I want to talk more clinically. Let's say with age, okay? What changes would you expect to happen in the blood vessel wall, the wall itself, as you age?
Hardening, less elasticity.
Less elasticity, it gets harder. It's like you're dealing with a pipe or a metal rod or a pipe that is becoming more rusty with time, okay? It becomes less, from like the very, very, very basic, it becomes less dependable, right? It doesn't function the way it used to, okay? So you have the veins. They have the ability to store a huge amount of blood, or they have the ability to deal with a change in volume with little pressure. With age, because the walls become stiffer and stiffer, this ability doesn't diminish, but it decreases. So here you will realize that with increase in the volume, there's a bit more steeper increase in the pressure. And the same thing, by the way, the same concept applies to the arteries. In general, your blood vessels become less compliant with the veins and the arteries. Veins they already have high compliance, arteries they have low compliance, but both of them become less compliant with age. And sympathetic stimulation, which is what I'm going to get into later on. Now, on to blood flow. So, to determine blood flow, we use Ohm's law. By the way, you need to know the equations. Allah يساعدكم. مهم. So you have the blood flow. Blood flow equals change in pressure over resistance. Again, change in pressure. Pay attention to this, okay? Dr. Adil likes to trick you on these, okay? Now, pressure is the driving force, right? So that means if I have increased, this is how I advise you to study the equations, by asking yourself questions. You don't just look at the equation and memorize it as numbers. No. If there's an increase in P, what would happen to Q? If there's an increase in R, what would happen to Q? Increase in Q would cause what? This way you think more physiologically, you can say. So if I increase the blood flow, okay, let's go back to the aorta. I increase the blood flow to the aorta through the heart. Okay, the heart pumps more blood to the aorta. There's more blood flow. What's going to happen to the pressure within the aorta? Increases. Right? طيب. And what would what would happen to the resistance when it, sorry?
Decrease or increase?
I was going to get to a point. As we go down into the arterioles, right? In this area, do I need more pressure or more resistance? More resistance. Why?
Slow the blood down.
To slow the blood down, exactly. So that means in areas where there is high pressure, there's going to be, where there's a lot of blood flow, there's going to be high pressure. Or a lot of pressure, there's going to be a higher blood flow, okay? And in areas with higher resistance, what's going to happen to the blood flow?
Slow.
It slows down. The flow slows down, right? Okay, so you have the pressure gradient and the resistance. They determine your blood flow. Do we agree? Tamam. Now, when we talk about flow, it could be laminar or turbulent flow, okay? Laminar flow is the normal flow, okay? Turbulent flow is where you could say there are bumps in the road. It could be of different reasons. It could be because of narrowing. It could be because of stiffness. There are many reasons that can basically disrupt the normal system. The normal system is laminar, where it is a smooth organized layer sliding over each other. The speed fastest in the center, slowest at the edge, and that's because of the friction of the walls. And the sound is silent. What do I mean by silent sound? You're gonna see it here. Turbulent flow, something is disrupting this normal flow. So you have chaotic, disordered flow, molecules bounce around. The sound is noisy. And by noisy, I mean heart murmurs. Do you know what murmurs are? What are they?
Sounds heard when the heart pumps blood. Sounds heard when the heart pumps blood.
Yeah.
No.
Yeah, abnormality.
Because you're not supposed to hear the sounds. The sounds that you're talking about is the lub-dub sound, right? This is the normal sound, this is normal. But between the lub-dubs, it's going to be silent. Because the heart has pumped the blood, now the blood is moving, okay? There's nothing disrupting the flow. But then, between the lub-dubs, when I hear some creaks or some sounds, we call them murmurs. This is an abnormal finding, this is pathological. And it usually indicates CVS diseases, okay? So you have laminar flow and turbulent flow. Now how can I determine the turbulence? Because if I see, okay, there's turbulent flow, how bad is it? Okay, or how can I determine if it's even turbulent or laminar? This is using Reynolds number, okay? So velocity times diameter times density over viscosity. Again, let's memorize the equation the way I told you to. Increase in velocity would cause what? Increase or decrease in the Reynolds number? Increase. Diameter, increase. If the density increases. And if I have increase in the viscosity, decreases, okay? A higher Reynolds number indicates what? Turbulent flow. Lower Reynolds number it basically says it's laminar flow, okay? Now, using this equation, what are the ingredients that can cause turbulence? Let's go one by one. Again, turbulence means higher Reynolds number. So whatever factor that causes a higher Reynolds number, we think of turbulence, okay? So velocity, if it should it increase or decrease to cause turbulence or to cause
Increase.
increase. Diameter,
Increase.
density, yalla.
Increase.
If it increases, what happens to the Reynolds number?
Increase.
What does it indicate? Turbulence or laminar flow? Turbulence or higher rate of turbulence. Viscosity. For me to have turbulence,
Should decrease.
it should decrease. I need to have less viscosity. The blood will become less. If the blood is less viscous, okay, it can cause turbulence. Okay. What are cases where what kind of case do I think of when I think of less viscous blood? Blood that is not so viscous.
Polycythemia. Polycythemia.
It's the opposite. Polycythemia, you have more blood vessels, red blood cells, right? Okay, let's think together. Poly means what? Many. If I have many, that means the blood becomes
More viscous.
Yeah. طيب. More or less viscosity would cause what to the Reynolds number? More viscosity, what would it cause to this number?
Decrease.
It decreases, right?
Okay.
طيب. So we think of the opposite. If I have turbulent flow, I might be thinking of anemia, right? Where the viscosity is less. And here we have the velocity and the flow. So the flow is the volume per unit time, velocity is the speed itself. And here it's just an idea. I've already covered this idea, by the way. At the capillaries, would the blood be moving faster or slower? Slower. And in the aorta? Fast. Okay? What would you expect the cross-sectional area to be? At the capillaries, would you expect it to have a large cross-sectional area or no? Why? Why would it be large and why would it be large?
Single capillary would have small, but bulk amount would be.
Yes. Thank you so much, Julie. So they're all together. You have larger cross-sectional area. What is the main reason behind this?
To speed up the nutrients exchange or the gas exchange.
The opposite. To slow down the blood to allow proper exchange. Because larger area, again, think of the numbers in a physiological manner. Larger area causes what to the velocity?
Increase.
Those guys, those are inverse.
Decrease.
Decrease. Those are inverse. Okay, those are direct.
But if there was more oxygenated blood in the area, then gas exchange would increase.
Yeah.
Okay, that's what.
But then with more oxygen, you'd have more carbon dioxide taken in. So you'd have more exchange, right? For proper exchange to happen, you need to give it time. Right or wrong? Again, when you go running, for example, at some point your chest starts to hurt, even though your heart is pumping a lot of blood to keep up. Why? Because your lungs are not getting enough time to exchange the gas, even though your heart is pumping more oxygenated blood. So technically I have more oxygen, but I don't have proper gas exchange to deal with the increased waste or the carbon dioxide. So this is the main idea here, is that the velocity plummets once it reaches the arterioles and then to the capillaries, okay? This is the same idea. Now, why do we hear a heart murmur in a narrow valve? Again, think of the numbers themselves, the equation.
Decreased diameter.
Decreased diameter.
Increased diameter.
Sorry?
Decreased diameter.
The valve is narrow. So what is happening to the diameter? Decreases. What happens to the Reynolds number? Decreases, right?
If it decreases, there should be laminar flow.
No, wait, I got confused now. Wait, Sadini.
What's wrong?
Why do we hear a heart murmur in a narrow valve?
It's
Mbella.
the velocity of
Because,
Oh.
no, it has, when we're talking about the valve, sorry, I mixed up the valve and the vessel itself. When you have a narrow valve, you're pushing against greater force to pump the blood out of the heart, right? Does that make sense? So, when I push harder, you know what the valves are, صح? You covered this in foundation. So when I have a narrow valve, I'm now pushing against greater
Velocity
pressure
increase.
to what? To propel the blood. What is going to increase?
Velocity.
Why? Because there's increase in pressure, right? So the velocity increases, what happens to the Reynolds number?
Increase.
Increases. So this causes turbulent flow. Does this make sense?
Yes.
Does this make sense? Then why might someone with severe anemia have a functional heart?
Low viscosity.
Low viscosity. We're getting to that part in a minute, okay? Now resistance. So you just basically switch up the equation a bit. Okay, again, think of it in the terms that in a way that I taught you how to think of it, okay? So if this increases, what decreases, and so on. And just to all agree, the beginning or the first arteries, the aorta and the muscular arteries, they have high what? Pressure resistance. They have high pressure, okay, low resistance. And then once we reach the arterioles, what goes down?
The pressure.
And what goes up?
Resistance.
Resistance. Okay. So then you have the total peripheral resistance, which is, from its name, it's when every single time or at every body tissue that I'm going to, cause the gas exchange and all that, at every body tissue, I'm going to face some resistance at the level of the arterioles and the capillaries, right? So we add up all the resistance from all the different body tissues, we get the total peripheral resistance. Do you get this idea? No. And the pulmonary resistance is going to be lower than the total peripheral resistance. Now the law of resistance, this is what we use to determine the level of resistance. So this is the equation, the main idea the doctor usually focuses on is the radius, okay? The relationship between the radius and the resistance. If I decrease the radius, the resistance increases, and if I increase the radius, the resistance decreases. But what you need to know is by how much, okay? Having the radius, cutting it by half, increases the resistance 16-fold, okay? And then the opposite, if I double the radius, the resistance is going to go down by 1/16 of its original number, okay? This is the main thing that I need you to take out from here, and the equation, of course. Now this is your part. So, hematocrit. Hematocrit is basically the density of the blood, okay? If I have more red blood cells, let's say, it will become what? More dense, right? More viscous, right? And Then if I have decrease in hematocrit or decrease in the viscosity, such as an anemia, I'd have a less viscous blood, right? Makes sense? Okay. So how does this relate to what we were talking about, which is Reynolds number? Again, this is an inverse relationship, ماشي? And to say it again, if I have a high Reynolds number, more than 2000, this is turbulent flow. If it is less, it is laminar, the normal flow. So if I decrease the viscosity, what's going to happen to Reynolds number?
Increase.
Goes up, right? If it goes up, what does this indicate? Laminar or turbulent? Turbulent. So in anemia, I would be experiencing a turbulent flow. Okay? And yeah, this is it. Polycythemia, what you were talking about, blood becomes sludgy and hyperviscous. The effect is higher resistance. And then you have anemia, low hematocrit, blood becomes thinner and less viscous. First you have low resistance, and second you have heart murmurs or turbulent flow. Okay? Just to make sure that I've covered everything here. Tamam. All good? Tamam. Yeah. Read, and whoever wants to answer, raise their hand.
See.
Okay, so this is vasoconstriction and vasodilation. So it's just because I was trying my best to cover everything in your slides in this session, okay? So there's things that I just go over very quickly. So just here are some factors that can cause vasoconstriction, where the blood vessels constrict. What happens if they constrict? Less blood goes through, okay? Vasodilation, that's when we dilate the vessels, more blood goes through, okay? What I want you to focus on is obviously oxygen and carbon dioxide and sympathetic and parasympathetic stimulation. Sympathetic stimulation causes vasoconstriction. Parasympathetic causes vasodilation. Keep that in mind for later. Okay, any questions until now? Now, resistors. So we have two types of resistors. What are they? Series and parallel. So in the series resistors, it's basically going in a linear manner. Okay, an example would be the artery, arteriole, capillary, venule, and vein. Okay, so if in the exam the doctor asks which of the following is an example of a series resistor, this is it. Okay, linear flow. And what's gonna happen? This is why I kept on emphasizing on the arteriole thing. The total resistance increases as you add more resistors into the series. Okay? Because you're adding more and more, so naturally there's going to be more and more resistance. However, the flow doesn't change. This is why at the very beginning I emphasize on the cardiac output and venous return. At steady states, the cardiac output is equal to the venous return because blood is going to be the same, okay? Because it's in a linear fashion. Unlike the parallel resistors that you're gonna see the difference in a minute. However, the pressure drops after each resistor. So the resistance increases if you add a resistor to a series resistors, and the pressure drops. However, the blood flow stays the same because it's literally just this. It's just one tube. Unlike the parallel resistors. Here, this is the example that I've showed at the very beginning when I was explaining the different blood demand and blood supply to different organs. They go in a parallel fashion. Why? Because as I explained to the girls, I don't know if you were there yet, different body parts need different amounts or different blood demand, right? So what happens here is you have the blood getting pumped out of the heart, and then now we have to divide the blood and give each tissue and each organ its right amount, okay? So in this case, the blood flow, is it affected?
Yes.
Yes. Why?
Increase in resistance.
No. The blood flow itself. I said that here the blood flow is not affected. But here I have, see, this is the aorta. Blood coming from the aorta, but the blood flow is now being distributed. So now at every single vessel, you're going, or at every single part of supply, you're going to have different blood flow than the original blood flow in the aorta. Does that make sense? So the blood flow differs. Why? Because the flow splits to to supply different paths. The resistance, however, decreases as you add more parallel pathways. Oh yeah, I forgot to talk about the equation. So the total in series resistance, the total is basically you adding them all together. Okay, this is why I said the resistance increases as you add more. So R1 plus R2, 3, 4, 5. If I add R6, the total is going to go up. Based on the parallel resistance equation, the resistance is going to be the opposite case. So I have, this is the equation, right? So 1 over R1 and plus 1 over R2 and so on. If I add a 7th resistor, okay, we're not going to say plus R6, we're going to say R7, we're going to say plus 1 over R7. In this case, this switches things and you're going to have a decrease in the resistance. So two things that you need to focus on in the resistors: series resistors, the resistance increases, okay? And parallel resistors, the resistance decreases, okay? And then the flow. The flow is the same in the series, but it's different in the parallel because it splits. Yeah, who wants to answer?
Indeed.
Bruh, raise your hand. The addition of parallel vascular circuit has what effect on the total peripheral resistance?
Indeed.
Yes, Malak.
Like you said.
Yeah, it is D. So because I explained one last time in the parallel resistors, if I add a resistor, the resistance decreases. Okay. Think of the equation as I said. Now this one, actually raise your hand for this one. I like the clinical questions; they're fun. Yeah.
B or D, but I'm thinking D.
You're thinking D. لا خليني نشوف كيف.
I think it's A.
I
What do you
think
think?
it's C. C.
What is B? Okay, what is affected? What is the main effect? What is the main effect? A 50-year-old patient undergoes a surgical procedure that removes one kidney.
So there's more
Parallel
blood flow to the other kidney.
There's more blood flow. بس انت ما تفكر في blood flow.
Resistance decrease.
نعم؟
Resistance decrease.
دقيقة ليش؟
إنه البارallel شلنا واحد increases.
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 انت حكيت.
Oh,
Yes. شو؟ نعم؟ It will increase because here I added a resistor to a parallel resistors. Okay, so the resistance decreases. But here I removed a kidney. Go back. I removed a kidney. I removed one of the paths, let's say. So what's going to happen? It's going to, the resistance is going to increase because we have less resistors now. Get it? Is it clear?
But how should I know when it's a parallel and when it's a series?
From the question. So usually you're not going to be asked this tough questions, but it's just to make it more challenging. This is why, because you were not here, Mashi, but at the very beginning, I explained to the girls, I emphasized on this part, okay, that the aorta supplies blood to the rest of the body, but it splits because, first of all, they have different demands. Some parts need more than the others, and because it needs to split, it can't, because you have different, different body tissues or different areas and all. So here, artery, arteriole, capillary, venular, vein. That's it. But when I say that I removed the kidney, that means I removed one of the paths. Get it? I removed, let's say, one of the roads that I need to supply. So what's going to happen? Imagine that you have, let's say, a main road that splits into 4 different roads. Yeah.
So like you removed one reciprocal, so overall the resistance increased.
Yes, according to the parallel resistance. When your question was, how do I know? It's because I mentioned the removing one kidney. Get it? Blood pressure. So pressure is the driving force. It is force over area. Okay? Now I'm going to be discussing I'll be going over definitions. So I have systolic pressure, maximum force, diastolic, the baseline. Pulse pressure is the difference between the systolic and the diastolic. Mean arterial pressure, this is what you need to actually focus on. Mean arterial pressure, this is how we calculated, and you see that we have more diastolic pressure than, we use more diastolic pressure than systolic pressure. 2/3 of diastolic, 1/3 of systolic. Why did we not just add those two and divide by 2? Because diastolic pressure is weighted more towards that, it is weighted more towards diastolic because the heart spends more time in diastole. Okay, because systole is usually there as a pushing force to supply blood. Get it? So just know the equation and just the terms. So this is the highest one, this is your the systole, this is the diastole. The difference between them is the pulse pressure. Okay, so if I have something that is decreasing my systolic pressure, what happens to my pulse pressure?
Decreasing.
It decreases. If I have something that increases my diastolic pressure, what happens to the pulse pressure?
Increases.
Decreases. Always think of it as a gap. The roof. You're thinking Malak. The roof is your systole and the systolic pressure, and the floor is your diastolic pressure. Okay. Always imagine just a gap. Okay. If I increase the roof, increase the systolic pressure, what happens to the gap? Increases. The pulse pressure increases. If I decrease the roof, decreases. That we decrease the gap. Think of the same for the floor. If I decrease the floor, we actually have more space now. The pulse pressure is higher. If I increase the floor, then the gap is smaller and we have less pulse pressure. But I want to focus more on the mean arterial pressure. Mean arterial pressure equals cardiac output times total peripheral resistance. We have explained these terms already. Cardiac output, the output that's being pumped out of your heart from via the aorta. Okay. Total peripheral resistance is all the resistance in the total of all the resistance in your body before during the gas exchange. Okay. The main thing I actually want you to focus on is mean arterial pressure is very, very, very heavily regulated in your body. Okay, it's always a priority. Even later on, inshallah, when you dive deeper into physiology, you're gonna see that even when someone gets involved into very, very bad car accident and they lose a lot of blood, their cardiac output is going down. The mean arterial pressure for a while still remains a bit normal because your body is trying its best through different mechanisms to keep the mean arterial pressure normal. Okay, because this mean arterial pressure is the main driving force of blood throughout your whole body. It's very important. Okay, so this is why I need you to focus on these two very, 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 very well. If one goes up, the other has to go down to keep the mean arterial pressure normal. Okay, always keep that in mind. So here we have the blood pressure components: systolic pressure, diastolic, and the pulse pressure. The main determining factors and just the explanation of each. I've already explained them. Okay, I'm not going to go into details. Just study it on your own. Now, here, I have the pressure. Okay, don't look at the systole, diastole. Just look at the pressure itself. From the proximal aorta to the capillary, what is going on? What is changing from the aorta to the capillary?
The pressure decreases.
It decreases. Why?
Because the resistance is increasing.
Because resistance increases. Okay. What do we call this? Damping. Okay. We call this damping. This is the damping of pressure as it goes further and further along the vessel. Now, abnormal pressure pulse contours. Again, these I'm going to go through them very quickly. Sclerosis. What does sclerosis mean? Stiffening. And stenosis, narrowing. Okay. So, in the case of aortic stenosis, something is blocking my aorta. Okay. So that means it is actually not able to push the blood out. So what would happen to the systolic pressure? It would go down because it's not able to push the blood. Okay? Is this clear? In arteriosclerosis, in any case where I have a vessel that is stiffened, that means it takes now more force to push or to propel the blood through it. Okay? So it takes higher pressure, so the systolic pressure increases.
But if there was narrowing down of the vessels, wouldn't it require more pressure to pump that same blood?
Yes, that is in the case of the valve, if you remember. But if the aorta itself is small,
Yeah, the aorta.
or it is narrowed.
Yeah, I thought of the valve.
Yeah. We're gonna do them very quickly together. Which of the following is the primary effect of decreased arterial compliance? I have decreased compliance. What does this mean?
C.
Hmm?
C.
Why?
Maybe B,
Why B?
because the equation is like delta V over delta P, I think.
Mm-hmm.
So like if we increase it, it will decrease.
So I have increase in the pulse pressure. I'll go a bit faster for in the questions, Mashi. If anyone has a question, you can come back to me after okay? During moderate exercise, a healthy individual's cardiac output doubles while their mean arterial pressure increases only slightly. The mean arterial pressure was not barely affected. Why? Even though they went for an exercise, so the cardiac output went really up.
C.
Yes, the resistance goes down to keep it normal. Okay? Yalla. Okay, Krista.
Yeah.
Wait, let me read the question.
Shouldn't it be D also, because it's like it's doing an exercise, so there is like increased heart rate.
There's increased contractility, right? What do you guys think?
It should be D and A.
Hmm?
And
Guys, what do you think?
هو D يعني
Isn't the pulse pressure normal? Isn't this pulse pressure normal? Like it's 100.
This is 170.
No, I mean if we subtract
You don't subtract in the systolic and diastolic.
pulse pressure.
it's
Oh, you're talking about the pulse
Pulse
pressure, yeah.
yes.
What
It
about-
says why did the pulse pressure?
What does this mean?
the resistance will increase.
Systolic.
It's D.
كمان routine physical. It has to be D.
D.
Wait, I'll go. Okay, مش موجود هون. I don't know where it went.
Which one are we
But guys, you have an increase in the systolic pressure. It's my mistake because I did not put the table for the normal ranges, okay? But you have an increase in the systolic pressure because the heart is pumping more blood. So there is increased contractility. So this is causing an increase in the systolic. Again, remember the gap. So now this 70, it's normal for a diastolic pressure, okay? So the floor is the same, but the roof has gone up. So I have widened pulse pressure. So I have and that's due to harder pumping. But it's okay if you didn't get it because it's my fault for not putting the normal ranges for systolic and diastolic pressures. I will be adding it in the slide. Like I did add it, but at the very, very, very end. It's my mistake.
We're not required to know them.
No. Wait.
No.
What did your doctor say?
No need to memorize them.
Not memory. You're talking about the blue table?
I think I confused the atrial or arterial pressure when it's pumped directly. I think because it's 100.
D.
120.
No, 120 is the normal systolic. But there was a calculation at the beginning that was like
I'm saying that
the pressure gradient at the systemic.
Oh,
I confused
okay,
these, so I
okay,
was like,
okay,
this is
okay,
normal.
okay. No. We're talking about the. You're talking about the pulse pressure itself, so we need to think of systolic and diastolic. Okay, you don't need to know the numbers as far as I know, but do know them. Like if you're talking about the blue table that is present in your blood pressure lecture, you don't need to know the numbers, but the least you can do is know what is normal and abnormal. Okay, because 170 systolic is like evidently abnormal. He wouldn't get if he got you numbers. I don't know if he'd get you because I don't know how they'd ask. He wouldn't. But if the doctor got you questions, it would be numbers that are clearly abnormal. Get it? Okay. Don't look at. Okay, so basically this is a low pressure. Okay, so 35-year-old woman presents with acute blood loss. I have hemorrhage. Okay. What is going down? I'm losing a lot of blood. What is going down? I explain this. Come on, guys. No. حبيبتي, I'm losing blood. I have less volume, صح? Less volume, less output, less cardiac
See?
output. To maintain the MAP as a reaction, what? No,
Increase the TPR.
increase TPR. Remember, please guys, I cannot emphasize this enough. Mean arterial pressure equals cardiac output times the resistance. One goes down, the other goes up to keep the MAP normal.
And how should you know the cardiac output was lowered? How should you know the cardiac
Because it says that she presents with acute blood loss. She's losing a lot of blood.
So stroke volume decrease?
Yes.
So cardiac output.
Hemorrhage, blood loss, all of that causes decreased cardiac output. Okay, does that make sense?
So to accommodate the pressure, the resistance.
The resistance goes up.
So if
A decrease in the
Yeah, exactly.
yes.
So
Yeah,
why not-
sorry, an increase in the resistance.
Why not see?
Why not? Yeah, why not see? Significant reduction in cardiac output.
Wait, it should be
So
C.
why does
They
it say
didn't ask.
isolated increase?
They didn't ask for the.
Yeah, they didn't ask.
for
I wrote the
response.
question wrong. Sorry, I was doing the slides at 1 a.m. The question should be why was the MAP normal? Okay, I'm gonna change it and present it back to you. Okay. Okay. Last one for this lecture.
C.
See, I have an increase in systolic pressure. Okay, diastolic pressure is still the same, and increase in the, remember the gap, the pulse pressure, because the systolic goes up. And now we go to the control of blood pressure. Okay, hopefully this is gonna take less time. Now what comes, okay, so I kept on emphasizing on the main arterial pressure. We need to keep the pressure normal, we need to keep the pressure normal. And that is done by the cardiac output and the total peripheral resistance. One goes up, the other goes down, right? What happens in cases where it is actually too, not severe, but I'd say where the MAP is actually affected? This is where I need to have a reflex, because the mean arterial pressure should remain normal. So I need to have a reflex to immediately bring it back to normal. So what constitutes a reflex? The receptor, then an afferent that's going to take the message that, hey, the blood pressure is too low or too high, to the integrating center, where it's going to make a decision of what to do, and then efferent pathway, that this is what you have to do, to the effector, okay? For the reflexes, it's either short-term or long-term, based on how severe the case is. If the if the blood pressure was affected for like a moment, then you have short-term reflexes, which is your baroreceptor reflex, and if it lasted for hours to days, then I have my RAS system, okay? So I'm gonna start with the baroreceptor reflex. Can I draw this one? Well, no, I can't. I can't, I don't think I can.
If you use the PowerPoint thing in the bottom, is this PowerPoint or no?
No, it's connected to the
Are you using Google Slides or
Google Slides. Okay, it's fine. Then I'll just explain the way it is. Okay. So in the baroreceptor reflex, first we start with the what caused the reflex. It's a change in the blood pressure. Either the blood pressure went too up or too down. Okay. Usually when it comes to the baroreceptor reflex, they deal with an increase in the blood pressure. Usually they also deal with decrease, but usually it's an increase in the blood pressure. Okay. Now we go back to the constituents of a reflex. First, I have the sensor. I need a place that senses that, okay, the blood pressure went too up. Okay, that is going to be at your aortic arch receptors and the carotid sinus. Okay, aortic arch, carotid sinus. Just know these names for now. The aortic arch has receptors that sense a spike in the blood pressure, and the carotid sinus also has that. Okay. Now I need to send a message that, hey, the blood pressure is going up. Who's going to send it for me? Who's the afferent pathway? The vagus and the glossopharyngeal nerves. From the aortic arch, I'm going to have the vagus nerve, nerve number 10, okay? And from the carotid sinus, the one who's going to take the message is the glossopharyngeal nerve, nerve 11, okay? Nerve number 9, all right? So, again, I have the vagus nerve and the glossopharyngeal nerves. They are the ones carrying the information that, hey, there's a spike in the blood pressure. So it is sensed by the aortic arch and the carotid sinus. from the aortic arch I have the vagus. Okay, a way to remember it is that you know how the aortic arch has an A. Okay, when you flip it, you have a V. Now it's vagus. Okay, so vagus number 10, and then you have the carotid sinus, which is the glossopharyngeal nerve or nerve 9. Then we need to take it to an integrating center. That is going to be in the brainstem, in your brain, an area called the brainstem. That's where it's going to make a decision that, hey, we need to drop the blood pressure, okay? And it's going to do that through multiple ways. Then you have, it takes the efferent pathway, sends the message that, hey, you have to do this, you have to do that, you have to do that. What are they gonna do? So I have an increase in the blood pressure, okay? You have the carotid sinus baroreceptors and the aortic arch baroreceptors. Aortic arch, which nerve?
Vagus.
Vagus, 10. Carotid sinus?
Sinus.
9. They're gonna go to the nucleus tractus, okay? You can know the name, you don't have to know the name. It's in your brainstem, okay? This is what it's gonna do. So I have high blood pressure, I need to lower it. So first we start from the heart. The heart needs to pump less, right? So it's going to activate something called the cardiac decelerator to decelerate the heart or to slow it down. And then it's going to inhibit the cardiac accelerator to slow down the heart, okay? Then it's going to inhibit the vasoconstriction. Remember vasodilation, vasoconstriction? So vasoconstriction is when I tighten the blood. Vasodilation is when I widen it. When I cause vasodilation, what happens is that the blood pressure drops, okay? Again, vasodilation, drop in the blood pressure, all right? And what causes vasodilation? Was it parasympathetic or sympathetic? Parasympathetic. There you have it. And now your blood pressure is back to normal, okay? So I'll go over it very one last time. I have the aortic arch and the carotid sinus. They're the receptors. They sense a spike in the blood pressure. They're gonna tell the vagus and the glossopharyngeal, hey, you need to tell the nucleus tractus that the blood pressure needs to go down. This happens by deaccelerating the heart and by causing vasodilation. Okay? What if I have hemorrhage? So I'm losing a lot of blood. So what does that mean? That means the blood pressure is going down, right? This is where basically it does the exact opposite. This is where the baroreceptor reflex becomes less active so that it doesn't prevent the body from trying to restore its high blood pressure. Now, usually both the carotid sinus and the vagus nerve, both of them can sense an increase in the blood pressure, but the carotid especially also senses low blood pressure, okay? The Valsalva is just a maneuver that is done to give us a proper assessment of the patient's baroreceptor reflex, if it is working well, okay? Just know this for now. If you want me, I can go into details about how it is done, but I don't think we have time. So I can explain to you after the session, okay? But for now, just know that it is a way for us to assess the baroreceptor's reflex. And here are some clinical applications of how the baroreceptor reflex acts in certain situations. Again, all of this is in your slides. This is just it includes everything basically. Yeah. So a patient experiences a sudden drop in blood pressure. Which of the following represents the correct baroreceptor reflex response to this change? Yes.
D.
Increased sympathetic activation, because I need to constrict the blood vessels to increase the blood pressure. Again, vasoconstriction causes what to the blood pressure? Increase. Vasodilation decreases. So if I have increase in the blood pressure, what's going to happen as a response? Parasympathetic vasodilation. If I have a drop in the blood pressure as a response, vasoconstriction, sympathetic. Yeah. Hemorrhage. What happens to the blood pressure? Goes what? Decreases. Yes.
D?
Yes. Constriction. Always think of vasoconstriction when you have drop in the blood pressure. Damage to the glossopharyngeal and vagus nerves would be expected to cause which of the following cardiovascular effects?
Tachycardia. D?
B. Yes, tachycardia and hypertension. Because we're unable to. No, wait. Yes, because we're unable to take the blood pressure down.
the glossopharyngeal and the vagus both do the same actions, right?
Yes.
But I remember the doctor in class saying that if they're damaged, they do the opposite effects. That's what I remember he said in class.
If it's damaged, it will
It is
increase.
B.
Okay, different. She will possibly.
He said if they're damaged, they're gonna cause.
No, he said
Yes.
like the nerve 9, if it's damaged, it would do some things, and nerve 10, if it's damaged, it would do the opposite of nerve 9.
Really?
That's what, like, I remember a student asking him, and that's what he said. But it's not mentioned in the
Do
slides.
you know anything? Do you remember
This is
anything?
physiology?
If it's
I don't think that's very accurate.
I don't remember him saying that. Do ask him, Mashi, and come back to me and tell me what he tells you. And if I was wrong, I'll remove the question from the slides, okay? Now on to the RAS system. This is my long-term reflex, okay? So, the RAS system, the baroreceptor reflex mainly deals with a spike in the blood pressure. RAS, a drop in the blood pressure, okay? So, the RAS system, the moment that it senses that there's a drop in the blood pressure, all of this happens to increase the blood pressure. Before I get into the mechanism, what effects do you think would happen? What effects do you think would happen when, again, the blood pressure, the RAS system senses low blood pressure? And it's been going on for a long time. Again, it's a long-term reflex, okay? So what kind of effects would I want to see?
Vasoconstriction.
Vasoconstriction
Aldosterone release.
Reabsorption of sodium.
and reabsorption of sodium, which will cause reabsorption of water, which will also increase the blood pressure, okay? Now let's get into the mechanism. So the liver has an enzyme called angiotensinogen, okay? This enzyme is very crucial for the activation of the RAS system. But this enzyme also needs to be activated itself, right? So the kidneys release something called renin. Renin is going to activate an angiotensinogen into angiotensin 1, okay? Angiotensin 1 also needs to be activated so that it causes effect. It gets activated by ACE, which is found mainly in the lungs, okay? Then we get angiotensin 2. That's where you have multiple effects. Number one, it stimulates the adrenal gland to release aldosterone. Aldosterone causes what reabsorption? Sodium. And angiotensin 2 on its own causes direct vasoconstriction and it also causes hormonal changes that can cause the release of ADH, which is I will be explaining that in a minute. Okay? So again, from the liver I have angiotensinogen, but angiotensinogen needs to be activated. Who activates it? Renin. Released by kidney. Now I have angiotensin 1. Now I need to get angiotensin 2. Which enzyme is going to cause this? ACE. Found in the lungs. And then you're going to have all of these effects. Is that clear? Is that clear? So angiotensin 2 exerts its pressor effect primarily through which mechanism?
B.
B. Why not A?
B. Because it doesn't release it.
It does not release ADH, yes. Which of the following is the primary stimulus for aldosterone secretion?
B.
B. An increase in angiotensin 2 would cause the stimulation of the adrenal glands to release aldosterone. Is this clear? Okay. Now we have volume reflexes. So blood pressure reflexes, we have short-term baroreceptor, long-term the RAS system, the renin, angiotensin, aldosterone system. Okay. Now what about the volume itself? If the volume is too low or if the volume is too high. If the volume is too low, ADH stimulates V1 and V2 receptors. V1 receptors cause vasoconstriction to increase the amount of volume into a certain area, and then we have V2 receptors which cause the reabsorption of water, okay, to increase the volume. What if the volume is too high? Especially in cases of increased atrial pressure. Remember those two words, atrial pressure, okay? You're gonna know more that later on, but increase in atrial pressure, I think of AMP. AMP is gonna bring it down. What is the opposite of vasoconstriction? Vasodilation. What is the opposite of reabsorption? Excretion. So it's going to excrete sodium and water excretion. Now, what I really want you to focus on is the output. low pressure receptors, okay, they can sense increase or decrease in the stretch, both increase and decrease. If there is increase, that means I have too much volume or too much blood, too much volume, yes. So that means, what do I need? ADH or AMP?
AMP.
AMP. So AMP is going to go up, ADH is going to go down, right? So we said AMP causes what? Excretion of sodium and water. Excretion. So what's going to happen to the urine output? Increases. Now here, decrease in the stretch. That means I don't have enough volume, okay? And usually not enough volume means not enough pressure. So now who's going to step in? ADH. ADH is going to cause vasoconstriction and reabsorption or excretion?
Reabsorption.
Reabsorption of water. Okay, and this is going to cause what? Decreased urine output. Okay? So if I have increase in the volume, I will be activating my AMP and I have excretion of water. If I have low volume, ADH is going to step in and is going to constrict and use the water it has instead of getting rid of it. A patient with heart failure develops elevated aldosterone levels. Which of the following is the primary mechanism by which aldosterone increases the blood pressure? C. Increased sodium and water reabsorption. Yes.
But the doctor also mentioned that aldosterone also constricts the vessels.
Yes, it does constrict, but the primary function is reabsorption. I'm going by like the basic functions of this. Yeah, it does have vasoconstriction effect. Activation of the low pressure volume receptors in the atria produces a decrease in the blood pressure, primarily through which of the following mechanisms?
B? Yeah.
Nope.
No.
Nope.
No.
Nope.
Let's start it.
فكروا فيهم واحدة واحدة. Again, activation of low pressure volume receptors in the atria produces a decrease in the blood pressure. يعني شو صار؟ اللي صار إنه I had a lot of blood pressure. I activated those stretch receptors. Go back here. I activated those stretch receptors. Right? So, why?
It should be increased AMP.
Okay, ماشي.
Increase
This is
AMP.
decrease AMP.
Yeah.
Okay then.
So, ADH is going to increase?
No.
No. I want the opposite effect.
Then
خذوا واحدة واحدة. Am I going to decrease
B.
AMP?
B.
خذوها واحدة واحدة.
خلاص.
Increase renal secretion? No. Decrease aldosterone production. Because aldosterone causes increase in the reabsorption. I want the opposite, right? I want to decrease the blood pressure. I'm gonna go through these very quickly. Chemoreceptor reflex. Those are other reflexes, okay? Chemoreceptor reflex. It detects low oxygen, high carbon dioxide, low pH, or acidosis. Low pH means what? Acidosis, okay? We have the central and the peripheral. The peripheral chemoreceptors, the sensors that we were mentioning, they're found in the carotid and aortic bodies. Central is found in the medulla, a region in the brain, an area in the brain, okay? Peripheral mainly senses oxygen, low oxygen. Central mainly senses carbon dioxide and pH, low pH, okay? What's gonna happen? Basically, if there's an increase in the carbon dioxide, the central chemoreceptors are going to increase the breathing rate, and then that's going to cause tachycardia, and then as a reaction you're going to have slight bradycardia, so it's a bit contradictory, but the final result is fine-tuning, okay? All right? So the main idea that I want you to take out of here is that those are the triggers: low oxygen, high carbon dioxide, and low pH or acidosis, and that the increased breathing does not happen because of low oxygen, it happens because of increased carbon dioxide. Why? Because what controls your breathing, other than, the blood pressure and all, but the breathing itself can be controlled by your higher centers, or the central chemoreceptors, okay? The central chemoreceptors, they detect carbon dioxide and pH, not oxygen. So, in severe sudden hypoxia, like in someone that is stroking, the bradycardia and vasoconstriction dominate. It's a last-ditch effort to preserve oxygen for whom? The heart and the brain. You guys were not here, but I was telling the girls that when we're talking about the parallel resistors, that part where each body part needs its own supply. some parts are high priority. So in cases of hemorrhage or extreme loss of blood, we prioritize these areas, okay? Then we have the vein bridge. It's not fully understood. All you need to know is that when there is increased venous return because of whatever reason, there's a sudden increase in the venous return or the veins are kind of clogged, it gets cloudy, the vein bridge reflex tells the heart to pump more to what? Go back to the venous return and the cardiac output concept. If the venous return is suddenly up, then what has to be up to accommodate cardiac output? That happens through tachycardia. And then you have the Cushing reflex. Cushing reflex is a life-threatening reflex. This is when you have increased intracranial pressure, okay? Sudden increase in the intracranial pressure or the pressure in your brain. This is going to cause vasoconstriction to limit the blood flow to the brain, to try to decrease it, okay? Now this sounds contradictory because we just said the brain is high priority. This is why it's life-threatening. Get it? So we have a sudden increase, for whatever reason, we have an increase in the intracranial pressure. As a response, there's going to be vasoconstriction to try to put that blood pressure down, right? So we're going to decrease the blood flow to the brain, decrease oxygen to the brain, decrease the pH, and increase carbon dioxide, right? And then you have what? What did we say about those two? Carbon dioxide increases, pH decreases. What's going to sense that? Chemoreceptor reflex, right? Now what is going to do is going to cause sympathetic activation to try to save the situation, because this is what it's sensing. It's not sensing this, it's sensing this, right? And then you have vasoconstriction. What happens? Widen pulse pressure, then increase stretch, increase the baroreceptor fire, and then parasympathetic activation. So it's very complex, right? All I need you to know, and all the doctor wants you to know, is the triad of the Cushing reflex. I have respiratory suppression, okay, because of the vasoconstriction. I have hypertension and bradycardia. So I have hypertension and bradycardia, they're together. Respiratory suppression, it all doesn't make sense, but it's a desperate attempt to save or to lower the intracranial pressure, which ends up being life-threatening. Yes?
So initially there's vasoconstriction, and then the sympathetic tries to push blood even though there is vasoconstriction.
Yeah.
معلش يا حب مقاطعة.
بس بدي 10 دقايق والله 10 دقايق والله عفوا. Yeah, so all I was saying is that really the doctor does not want you to know the whole process, okay? He just wants you to know the triad. I don't think he even wants you to know the triad, by the way. He never asked us about this, but as Julie has already mentioned it, sometimes the doctors will be adding things that they wouldn't ask you about, but they're very clinically relevant and they're very important in hospital settings. Cushing reflex is one of them, okay? So very quickly, chemoreceptor reflex, it senses increase in the carbon dioxide or decrease in the pH, okay? This causes like multiple reactions to try to fine-tune the rhythm. Then I have vein bridge reflex. This is to equal the cardiac output and the venous return. Cushing reflex happens in cases of what? Increased intracranial pressure. Respiratory sinus arrhythmia, this is a sign of a healthy rhythm. Basically, the overall net effect is that with inspiration, there's going to be increase in the venous return, which is going to cause increase in the heart rate to, again, to accommodate with the increase in the venous return. So the cardiac output is going to go up, okay? Just know the concept that this is a sign of a healthy person, okay? Because if the body is immediately able to accommodate to change in the venous return or change in the cardiac output, then that is a healthy body.
Is it arrhythmia irregular rhythm?
I think this is an example. We're talking about the healthy rhythm, how it should be, okay? Then you have hypertension, the silent killer. This is just for memorization, okay? Hypertension, you have chronic persistent elevation of the blood pressure above normal. And by the way, this is relevant also in the Valsalva maneuver, okay? Because their centers are basically less sensitive to the increase in the blood pressure because it is chronically or constantly elevated, all right? So you have two types, you have the primary and secondary. Primary is hypertension on its own, and secondary is hypertension that happens as an effect to another illness. This is the table I was talking about. I should have put it earlier. No, you don't need to know the numbers, okay? And just know what is normal, what's not normal. Usually it's like 120, systole is like 120 over 1 or 120 over 80 is usually like the normal, okay? And this is the negative feedback loop. It basically says an increase in this causes decrease in that. So for example, I have an increase in the blood pressure. What do I need to do? Vasodilation, vasoconstriction.
Vasodilation.
Vasodilation. So the better receptors they increase the firing rate, whatever, then you end up with vasodilation, reduced blood pressure. It's basically, it's more of a very simplified concept map of everything we took today. This includes everything in your physiology that is included for CVS, that is included in Midunit, okay? I tried my best to not miss anything from the slides, so you can use this as a last minute revision. Okay, if you have any questions, you have my number, and I would be more than willing to help. I really hope this was useful.